এমনিতে বাদ দিল তো।
না 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 আবার কোশ্চেন কখন
ইয়ে তো আগ বলে
সরি না না মনে কিন্তু সবই তো একটা বেজে গেছে না
আপনারা দুজন কি পাশাপাশি বসছেন? ইকো হচ্ছে, দোলা আপু আর আপনি
ঘন্টা
ডিফারেন্ট রুমে বসতে হবে, নালে খুব ইকো হবে।
রাইট, ঘন্টার শব্দ হচ্ছে। হ্যাঁ, সবাই মিউট করে সুন্দর করে ঘন্টা কিন্তু একটা আওয়াজ আসছে।
কোথায় বসবো?
একটা ঘন্টার আওয়াজ হচ্ছে না কেমন?
ওটা দিচ্ছে ম্যাডাম, উনি ঘন্টা দিয়ে প্র্যাকটিস করছে।
এখন কি ঠিক আছে না? ইকো হচ্ছে না তো? আমার কথা শোনা যাচ্ছে তো ঠিক মতো?
ইকো হচ্ছে দোলা আপু,
ইকো হচ্ছে? দুইজন
এটা
দুই
হবে
রুমে যাও
ইকো।
তারা দুইজন দুই রুমে যাও। হ্যাঁ, পাশাপাশি থাকলে হবে।
আর সাউন্ডটা, হ্যাঁ সাউন্ডটা দুজন না গেলে
সব পাঠিয়ে দিচ্ছি, আপনি যান। হ্যাঁ, আপনি শুধু এই যে ল্যাপটপের তারের কানেকশনটা খুলে যান, ওরা দিচ্ছে।
এখন ঠিক আছে? একটু কথা বলো, শুধু একটু কথা বলো।
মিউট করে দিলে হবে অবশ্য, যে কথা বলবে সেটা বাকিরা মিউট করে দিলে অসুবিধা হবে না। আসসালামু আলাইকুম ম্যাডাম।
ওয়ালাইকুম আসসালাম। এখন কিন্তু ভালো লাগছে, কোনো শব্দ মানে এক্সট্রা শব্দ লাগছে না।
আসসালামু আলাইকুম। এই রুম কি?
জি ম্যাডাম।
একটা ছবি তুল স্ক্রিনের, আমার মোবাইলে একটু প্রবলেম হচ্ছে।
ম্যাডাম আমিও মোবাইল থেকে নিচ্ছি।
আচ্ছা আমি তুলে দিচ্ছি।
আব্বাসি তুলে দিবে, আব্বাসির এগুলো খুব সুন্দর হয়, আমাদের এত সুন্দর হয় না।
আমি তুলে রাখছি, আপনাকে পাঠিয়ে দিব।
কি হচ্ছে? এখন ঠিক আছে মনে হয় না?
হ্যাঁ,
সবাই হাসেন, স্মাইল স্মাইল। থ্যাংক ইউ। আমি মডারেটর গ্রুপে দিয়ে দিচ্ছি।
বন্ধ করে দেন। জি
তুলো, তখন দিলীপ ছিল না, আরেকটা তুল রুমকে, আরেকটা তুল। দিলীপ ওর মাথা কেটে যাচ্ছে, স্ক্রিনটা একটু করো, দূরে করো।
ম্যাডাম একটু স্ক্রিনে থাকেন।
হ্যাঁ, আছে না?
একটু মাঝখানে চলে আসে।
ঠিক আছে, থ্যাংক ইউ।
ওকে, বন্ধ হয়ে গেল কেন সবাই? সাউন্ড
আমরা কি শুরু করবো ম্যাডাম? অলরেডি 8টা বেজেছে, 8:03।
হ্যাঁ, অবশ্যই শুরু করবো। তোমার চেয়ারপারসনরা আসছেন না? কি?
জি ম্যাডাম।
শুরু করো।
ম্যাডাম দিলীপ স্যারের সাউন্ডটা অনেক চেক করে নেওয়া ভালো। স্যার কথা বলতে পারছিলেন না, এতক্ষণ শোনা যাচ্ছিল না।
দিলীপ, তোমার সাউন্ড চেক করো।
দিলীপ স্যার আপনি একটু কথা বলেন স্যার।
কষ্ট করে একটু চেক করে নাও, শুরু তো এক্ষুনি হবে।
আচ্ছা, রুম কি
ম্যাডাম?
ওলা রুম কি তোমরা শুরু করে দাও, কারণ অলরেডি 8:03। শুরু করে দাও।
জি ম্যাডাম, আমাদের একদম টাইট শিডিউল। Dear participants, ladies and gentlemen from home and abroad, Assalamu alaikum and good morning. I am the reporter Dr. Sharmin Siddiqui, welcoming you all to this 30th International Scientific Conference 2022 of Obstetrics and Gynecological Society of Bangladesh. Our session is obstetrics session with the theme Healthy green recovery to combat climate change, where we have 3 chairpersons and 6 speakers. Now I am requesting Dr. Runa Akhtar to moderate whole session.
Thank you, Dr. Sharmin Siddiqa, for giving me the floor. Dear audience from home and abroad, Assalamu alaikum and very good morning to you all. Our today's session is about obstetrics and duration is 1 hour. It's really wonderful to be a part of this session. Our today's session, ladies and gentlemen, you have already informed that we have 3 chairpersons and 6 speakers today. Each speaker will have 8 minutes to deliver their speech. We will warn her after the end of 6 minutes. I humbly request all the speakers to complete their presentation within minutes. Current audience, if you have any questions, please put in the chat box so that we can discuss it at the end of the session if time permits. It's my pleasure to introduce our chairperson of the sessions. Our first chairperson is Professor Parul Jahan Madam, Professor and Head of the Department of Obstetrics and Gynecology, Women's Medical College and Hospital, Uttara, and is a member of OGSB. Now introducing our second chairperson, Professor Shamim Fatima Nargis Madam. She is ex-professor of Sir Suleiman Medical College and Hospital, and she is a member of OGSB. Now introducing our last chairperson, he is Dr. Professor Dilip Kumar Bhomik sir. His principal and head of the Department of Pargu Medical College, Sylhet, President OGSB branch Sylhet, and editor-in-chief Pargu Medical College Journal. We have 6 speakers today. Now we are going to start our session. I would like to call upon our first speaker, Dr. Kakuli, Associate Professor of Women's Medical for Women and Hospital, to deliver her speech. Her topic is use of antiplatelet and anticoagulant in treating oligohydramnios, our experience at MCWH. Over to you, Dr. Kakuli Saha.
সুপ্রভাত সকলকে ধন্যবাদ ডক্টর রুনা আক্তার দোলা আমাকে 30তম ইন্টারন্যাশনাল কনফারেন্সের ওপেনার বক্তা হওয়ার সুযোগ দেওয়ার জন্য। সবার প্রথম আমি সব শ্রদ্ধা ভরে স্মরণ করতে চাই আমাদের ভাষা শহীদদের, যাদের আত্মত্যাগের বিনিময়ে আমরা পেয়েছি আমাদের রাষ্ট্রভাষা এবং যার হাত ধরে এসেছে আমাদের স্বাধীনতা ও আন্তর্জাতিক স্বীকৃতি। আর আজকে আমার টপিক and anticoagulant in treating
Our first speaker is Dr. Shirin Jahan. She is the junior consultant deputed to Department of Reproductive Endocrinology and Infertility.
Zinat Madam থেকে আসতেছে, Zinat
that protect fetus from injury and allow room for movement and development. It also helps umbilical cord from being compressed between the fetus and uterine wall. In addition, amniotic fluid reflects the urine output of the fetus, measure a fetal well-being. So oligohydramnios is the serious condition for the obstetrician for fetal outcome. It is referred to a low level of amniotic fluid during pregnancy, normal amniotic fluid volume change with the age. It is defined by amniotic ASOC 2004 defined amniotic fluid index that is below the 5th percentile for gestational age and is thought to affect approximately 4.5% term pregnancy. It also be described amniotic fluid volume is less than 500 ml at 32 to 36 weeks of gestation. Maximum vertical point is less than 2 cm, AFI less than 5 cm and less than 5%. Here is the diagram of the normal amniotic in fluid index. We see here the blue color is the when it is the less than 5%, it called oligohydramnios. We everybody know the etiology, but here our concern is more placental insufficiency resulting in the blood flow during redistribute to the fetal brain rather than abdomen and kidney. This causes poor urine output. Also related with renal agenesis, non-functioning fetal kidney, obstetric uropathy, genetic, even viral infection also cause the oligohydramnios as well as polyhydramnios. Pathophysiology of the oligohydramnios, the volume of the amniotic fluid increased steadily until 33 weeks of gestation. It plateaus from 33 to 38 weeks and then decline, with the volume of the amniotic fluid at term approximately 500 ml. It is predominantly comprised of the fetal urine output with a small contribution from the placenta and some fetal secretions. The fetal breathes and swallow an amniotic fluid. It gets processed, fill the bladder, and is void, and the cycle repeats. Problem with any of this structure in this pathway can lead to either too much or too little fluid. Anything that reduces the production of urine, block the output from the fetus, or sometimes the rupture of the membrane also can lead to the oligohydramnios. But our concern is the placental insufficiency. Here we see the sonographic image. I want to say that in case of oligohydramnios, we have to also measure the kidney size. Oligohydramnios is the second trimester carrier of the poor prognosis. It is the majority of the case. There is a premature rupture of the membrane with the subsequent premature delivery and the pulmonary hypoplasia, which can cause significant respiratory distress at birth. When the oligohydramnios is assessed with the placental insufficiency, there is also a higher rate of preterm deliveries, usually though planned induction of the labor. These cases will carry a poorer prognosis than that a normally growth fetus. Amniotic fluid also allow the fetus to move its limbs. Without amniotic fluid, fetal can develop severe muscle contracture, which can then managed by physiotherapy after birth. Some literature shows the low amniotic fluid is a frequent finding in the pregnancy involving the IUGR is more likely due to the decreased fetal blood volume, renal blood flow, and fetal urine output. No treatment has been proved effective long term, but short-term improvement of the amniotic fluid is possible and might be done in certain circumstances. Use of low-dose aspirin and low molecular weight heparin, enoxaparin, is the safe during pregnancy, and it improves the fetal outcome. We see some review literature from the international journals. Heparin successfully improved an early onset of growth retardation accompanied by the severe oligohydramnios. Evaluation of efficacy of aspirin, low molecular weight heparin in the patient with the unexplained intrauterine growth retardation accompanied by the early onset of oligohydramnios. And the British journal also saw the low molecular weight heparin to prevent the placenta-mediated pregnancy complication. And the role of inflammatory cytokine and the local placental thrombosis in patient with the unexplained intrauterine growth retardation accompanied by the early onset of oligohydramnios have been shown. Since the low molecular weight heparin and aspirin have both anti-inflammatory and anticoagulant effect, we evaluate their efficacy in the patient with the unexplained IUGR accompanied by the early onset of oligohydramnios. Bleeding is the potential complication. Low molecular weight heparin do not cross the placenta and therefore no associated with the bleeding in fetus and no teratogenic effect. It is a higher specificity for the factor 10A and have fewer effect on the platelet activities. As a result, it may cause bleeding less often and also less risk of the heparin-induced osteoporosis. Lower aspirin also show the prevention and treatment of preeclampsia and IUGR. Lattice et al. Also did a meta-analysis on the low-dose aspirin, and multicentric study by the Foxy also show the low-dose aspirin and the good fetal outcome. Our experience in the MCWS, in between the 1st June to 1st October 2021, we take the 3 patients aged from the 22 to 30 years of old from the 24 to 30 gestational week with unexplained IUGR and oligohydramnios. After proper evaluation, we use the thromboprophylactis and aspirin 75 milligram orally and the enoxaparin 60 milligram subcutaneously apart from the usual protocol, and get the good result, and which also involve the frequent follow-up, ultimately live birth rate and obstetric complication, prenatal complication, hemorrhage, and side effect also recorded. Among the 3 patients successfully delivered 2 patients. So our success rate was 66%, and 1 pregnancy ended in the missed abortion, and so failure is the 33.3%. On conclusion, I want to say the aspirin and low molecular weight heparin is successful in the treatment of the IUGR, accompanied by the early onset of oligohydramnios by increasing the rate of live birth with few side effects for the both mother and the fetus. Case number is the very limited and observation time also the limited. And thank you all for the patience hearing. Dhanyabad.
On time.
Wonderful presentation. Dear audience, we are going through a crucial time in COVID-19 pandemic. Our next topic is about COVID-19. And the topic is mental state of pregnant women during COVID-19 pandemic in Bangladesh. Speaker is Dr. Fahmida Rashid, Assistant Professor, Chittagong Medical College and Hospital. Over to you, Dr. Fahmida Rashid.
Assalamu alaikum and very good morning to you all. I'm Dr. Fahmida Rashid, presenting on behalf of my team on mental health of pregnant women during COVID-19 pandemic in southeast region of the Bangladesh. The COVID-19 pandemic is the most devastating infectious disease in recent history. Over 380 million people infected till date and more than 5.7 million people died. COVID-19 pandemic affect mental health of global population from child to old, men to women, non-pregnant to pregnant. In 22nd March 2020, first cases of COVID-19 was detected in Bangladesh. To contain the spread of virus, limited provision of face-to-face medical service were installed. Medical visit and routine follow-up restricted to emergency and serious cases during this lockdown period. COVID-19 pandemic produced changes in the routine of whole society, especially lifestyle habits. Measures taken to restrain the virus spread, distancing, quarantine, strict hygiene measures. You all know that pregnancy is a beautiful magical time in women's life. Pregnant women are commonly afflicted by mood symptoms. COVID-19 pandemic clouded pregnancy with fear, anxiety, and uncertainty. From the previous study findings, it was seen that infectious disease outbreak increased the risks of anxiety and negative feeling among pregnant women. During COVID, scarcity of treatment and hospital facilities during lockdown worsened the situation of mental state of pregnant women. The cause of fear were fear of contagion, uncertainties about the new virus, concern of fetus, fear of vertical transmission, potential death of the close one, fear of miscarriage, prematurity, fear of fetal anomalies, fake information via social media, and possibilities of unemployment of partner. For that, what women did, they avoid contacting hospitals, they withdraw themselves from ANC schedule, so that result decreased overall medical control over the pregnancy. So we did a study to see to assess the effect of COVID-19 pandemic on psychological and anxiety state during pregnancy. It was a cross-sectional study done during the period of October to December 2020, 6 months after the outbreak of COVID-19 in Bangladesh. About 553 pregnant women were participated. We used some sort of tools. The first tool we used.
Are you moving the slides?
Yeah, ma'am.
আমরা কিন্তু স্লাইড দেখছি না, ফার্স্ট স্লাইডই দেখছি।
ম্যাডাম আমি তো স্লাইড মুভ করছি,
একটাও আসে নাই রে, ফার্স্ট স্লাইডই চলছে তো।
তুমি ফুল স্ক্রিনে যাও তাহলে হবে।
না ম্যাডাম করেছি আমি,
ফুল স্ক্রিনে যাও, ফুল স্ক্রিন।
এখন দেখা যাচ্ছে ম্যাডাম?
এখন দেখা যাচ্ছে কিন্তু আমরা
এখন স্লাইড এসেছে, একটা চেঞ্জ স্লাইড
এসেছে। এখন
দেখো না, তুমি ফুল স্ক্রিনে যাও।
এখন ম্যাডাম মুভ করছে?
না
জি ম্যাডাম মুভ করছে না।
নো
ফারজানা আপনি কি একটু
আমার কথা শোনো, তুমি আগে ফুল স্ক্রিনে যাও, তারপরে
ম্যাডাম ফুল স্ক্রিনে গেছি, ফুল স্ক্রিনে গেছি।
ফুল স্ক্রিন আমরা দেখতে পাচ্ছি না রে, সাথী
শেয়ার করেন।
আমি তো আমরা ফুল স্ক্রিন দেখতে পাচ্ছি।
ফারজানা একটু প্লিজ শেয়ার করেন তাহলে আপনি।
Cervical cancer is a unique cancer that is highly preventable and all age can be affected.
হ্যাঁ এখানে যান।
এবার আসছে,
এখন আসছে।
ফারজানা প্রথমটা দাও তাহলে।
সময় কুলাবে না, তাড়াতাড়ি যাক।
Action by WHO.
তুমি চলে যাও।
I'm sorry. Please move forward, please.
Cervical cancer is targets for two pillars of action. That is the vaccine.
Move on, please. Yeah.
And we are
Move on.
And if you want to achieve this goal,
Yeah. So we did a study to assess the effect of, and 553 pregnant women were participating in this study. Move on, please. So we use two tools to move on, please. Just move on. Yeah. Move on, please. To see the psychological impact. Back, please. It's very difficult when the person. Yeah, back one. Just when to see the psychological impact of COVID-19, we used psychological impact questionnaire, the Italian version of the revised impact of even scale. A score of more than 24 was taken as meaningful. And move. And it has 3 subscale: intrusion, avoidance, and hyperarousal. Next. To see the anxiety state, we used another scale. Next. A 6-item short form of Spielberg state trait anxiety inventory state scale. And next, a score of more than 36 was taken as a significant. Next. So we translated the questionnaire into Bengali and retranslated it again by a translator. We taken approval from the Ethical Review Committee, Chittagong Medical College. Next. Next. So now come to the result. Psychological impact of COVID-19 by IESR score, the mean score was 25.65, and among them, among the 3 subscale, hyperarousal contribution was more. Next. So our the score of, as you know that, a score of more than 24 was taken as a meaningful, so our result is significant. Next. In the psychological impact of COVID-19 by IESR score, 54% in women, pregnant women, the score was more than that of normal. Next. And contribution of the avoidance and hyperarousal were significant. Next. To measure the anxiety state, 6 score were used, and our study mean were 40.55, which is significant. Next. 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 So psychological impact, IESR avoidance and hyperarousal were significant. In anxiety, a significant difference was observed in the mean STI-6 score. Next. Among the socio-demographic characteristics of there was no difference in the age distribution. Next. Move, please. Move. And the women who came from the urban area are having more score than that of rural. Next. Next. The women who visited the private center are having more psychological impact than that of government sector. Next. There is no difference in educational status. Next. No difference in the socioeconomic status. Among the socioeconomic status, the women who came from the middle income country are more having psychological impact than that of lower and high. There is no difference in the gestational age and no difference in the parity. We also sorted out some information related to COVID-19 and physician consultation related information like history of COVID-19, physician consultation during pandemic, type of consultation, frequency of consultation, satisfaction about the consultation. Among them, the patient who visited not visited the doctor are having more psychological impact than that of who visited. Next. We also sorted out some history and lifestyle of pregnant women, like history of COVID, postpartum depression, psychiatric disorder, financial status in the last 6 months, sleeping hour, physical activity and habits of exercise, food intake, behavior with family member. Among them, the financial status was significantly deteriorated, and women who slept less are having more psychological impact than that of who are not having sleep more than 7 hours. Next. Next. So in recent meta-analysis, pregnancy during COVID-19 pandemic shows that there is a depression in 31% women, anxiety in 37% women. Prenatal mental health is very crucial to physical and psychological health of the mother and the fetus. Next. Prospective study result shows that serious perceived stress was significantly associated with shorter gestational time, lower birth weight, lower APGAR score, and higher rates of complication in both fetus and mother. Pregnancy with COVID-19 causes low birth weight, perinatal death, preterm delivery. And prenatal stress, depression, and anxiety has negative effect on neurodevelopment, cognition, temperament of the newborn. So what is the solution? We should provide correct information, engage in healthy behavior, screening test for psychological problem, and promotion of protective factor and COVID strategy. Next. So COVID-19 pandemic, previous one. COVID-19 pandemic is associated with a negative psychological impact on pregnant women. Level of anxiety and stress in pregnancy has increased as a result of COVID-19. So longitudinal study is needed to confirm this result. Next. So at the end, I want to say, at the minute, times are tough. The self-isolation can be rough. Day after day, night after night, the future unfolding is not so bright. The world seems so strange, just not the same. So we have to get through this period. Hopefully, we'll get through this period. Thank you very much.
Amita, for your presentation. I humbly request all the presenters. I would like to request Professor Parul Jahan Madam to say something about the presented topics and the presentations. Ladies and gentlemen, our respected chairperson, Dr. Parul Jahan Madam.
Thank you. Very good morning in this obstetric session of 30 International Scientific Conference 2022. There are the two presenters, Dr. Kakuli Shah and Dr. Famida Rashid. Dr. Kakuli Shah, thanks to Dr. Kakuli Shah because she has completed in time. And this topic also was the important topics because oligohydramnios is a really problem and it is a nightmare for obstetricians. And she told that antiplatelet and anticoagulant treating is a very ambitious for the oligohydramnion patient. So it is though it only three, she took only research on only 3 patients, but I think more patients should be in investigations and in research, and then we can tell properly. And then next, Dr. Famida Rashid, she has a very important topic because nowadays the COVID-19 we are facing. So though her presentation is very quick, even then she's a very nice, elaborate presentation, and she told that we can overcome this by frequent doctor's visit, by counseling, and by sleep, and by maintaining the proper counseling and proper with the families and with doctors. We can maintain her, we can improve our psychological condition, that we have seen. So thank you the two presenters for their very nice presentation. Thank you.
Thank you, madam. Our third presenter is Dr. Ismat Jahan. She is working as assistant professor in East West Medical College and Hospital, Dhaka. Our topic is gestational scoring for P in pregnancy, a real fortune teller. Over to you, Dr. Ismat Jahan.
Respected chairpersons, distinguished guests from home and abroad, learned audience, Assalamu alaikum and very good morning. I am Dr. Ismat Jahan. Welcome you all to my presentation. My topic is gestational scoring for preeclampsia in pregnancy, a real fortune teller. Preeclampsia is a multi-system progressive disorder after 20 weeks of pregnancy, characterized by the new onset of hypertension more than or equal to 140/90 millimeter of mercury. This is associated with proteinuria or new onset of significant end organ dysfunction with or without proteinuria. Maternal organ dysfunctions may have kidney, liver, neurological, hematological, and uteroplacental involvement. So it is a major challenge in modern obstetrics for early identification of pregnancy at risk for preeclampsia and to undertake necessary measures for the needful. A careful history taken early in first trimester can warn attention for effective prediction and prevention towards mothers at risk very early. This can be done by any healthcare worker by using HTP gestosis score. Regarding rationale of this study, for the prevention of hypertensive disorder of pregnancy, its prediction is crucial. FIGO recommends first trimester combined test with maternal risk factors, measurement of mean arterial pressure, serum placental growth factor, and uterine artery pulsatility index. There is an unmet need in recognizing and managing HDP and its complication in low and middle income group countries. This study was done rationally as in low resource settings where non-availability of biomarker testing facility is the reality. The simple maternal risk model has been restructured as hypertensive disorder of pregnancy gestosis score by organization gestosis. Regarding materials and methods, a retrospective study was conducted during the period of January 2018 to July 2019 in a private medical college hospital. During this study period, 73 cases were enrolled who developed preeclampsia at third trimester of pregnancy. Enrolled patients filled up the questionnaire containing the checklist for gestosis score after taking informed written consent. Also, the previous antenatal and medical records were checked, and those were included in questionnaire form by the investigators. 7 cases were dropped out as they could not fill up the questionnaire completely. Gestosis score more than or equal to 3 is marked as at risk for preeclampsia. Based on clinical questionnaire, the individual parameter was scored as 1, 2, 3 as recommended by FOXI, ICOG, and Gestosis India. Here showing the HDP gestosis score. These risk factors are assigned as a score 1. And this HDP gestosis score, these risk factors are assigned as score 2. And these risk factors are assigned as score 3 in HDP gestosis score. So the general objectives of the study are enrollment of PE cases in last trimester of pregnancy to check back the risk factors, those were present at first trimester of the study population, to fill up the questionnaire for PE cases containing the points of HDP gestosis score, to find out the association of risk factors with development of preeclampsia enclosed in HDP gestosis score. And the ultimate objectives are to predict the development of preeclampsia clinically in a low resource settings, to prevent the complications of PE by predicting clinically at first trimester. So, our inclusion criteria includes pregnant women who develop new onset of hypertension more than or equal to 140 by 90 millimeter of mercury after 20 weeks of pregnancy, along with new onset of hypertension, coexistence of any of the following new onset condition: proteinuria or albumin creatinine ratio more than or equal to 8, other maternal organ dysfunctions, including features such as renal or liver involvement, neurological or hematological complications, or uteroplacental dysfunction, and chronic hypertension with superimposed preeclampsia. Now moving towards the results. This figure 1 shows the age of the study population. This figure shows that most of the study population belongs to more than 35 years group. This table 1 shows the number of study population having gestosis score more than or equal to 3. This table shows that among 66 cases of the total study population, 31 cases, that is 46.96%, are having gestosis score more than or equal to 3 at booking visit. Table 2 shows the number of cases having gestosis score more than or equal to 3 in different age groups. This table shows that gestosis score more than or equal to 3 is more in extreme of age group, that is more than 35 years and less than 19 years. This table 3A, which is risk factors assigned as score 1, among the variables of score 1, Primary gravida, age more than 35 years, less than 19 years, BMI more than 30, mean arterial pressure more than 85 millimeter of mercury are found significant in number. And from table 3B, risk factors assigned score 2, among the variables, we found maternal hypothyroidism is significant in number. Table 3C, which is risk factors assigned as score 3, among the variables, chronic hypertension is found significant in number in this study. Regarding discussion, this study was compared with other studies, and most of the variables of this study were found similar. And unfortunately, there was one limitation of this study. From booking antenatal and medical records, we could not find the laboratory investigations related to dyslipidemia. So these variables from risk score 1 could not be included in this study. And in conclusion, I want to say universal screening for preeclampsia is the cry of the moment. Biomarkers for detection of P is costly and not widely available. So assessment of clinical risk factors can be of great help in identification and prevention of P in susceptible cases. Gestosis score is an objective, dynamic, simplified, and feasible quantification of maternal risk factors for effective screening of P, especially in a low resource settings. Except primary gravida, all other risk factors are modifiable. It is recommended that health workers should use the gestosis score as a screening tool for preeclampsia prediction and early diagnosis. And further studies are demand of time to understand the regional and racial variations in high, moderate, and low risk factors of HDP. Thank you all for patient hearing.
Thank you, Dr. Isma Jahan. Very interesting and important study indeed. Placenta acquita spectrum diagnosed during C-section of surgical team is our next topic, and the presenter is Dr. Bodrunnisa Begum, Associate Professor, Shohid Nazrul Islam Medical College. Over to you, Dr. Bodrunnisa Begum. Dr. Bodrunnisa Begum.
Unmute করতে হবে, unmute করতে হবে.
Yes. Okay, now can I start? Can you hear me?
Yes.
Okay.
শোনা যাচ্ছে?
Good morning to everyone. I am Dr. Bodrunnisa. Actually, I am now working in Adin Shokana Medical College. That is express. It is my previous previous position. Sorry for that. At first, now again, good morning to everyone. I am very much pleased to share with you in this conference, and I want to give thanks to all. So my presentation is so sensitive and emerging issue nowadays, and we know all of us, those are dealing with the high risk patients. In this picture, this is my picture, my one patient picture, that is, we can assess the situation actually, these cases.
Madam, would you please,
sorry?
Go to the full screen? We cannot just see the full screen of your presentation. Would you go to the full screen of your presentation?
Slide show হচ্ছে না.
Slide move করছে না.
Move করছে না.
No, that's okay. Okay. Okay, this is actually a heterogeneous complex disorder of arthroplastic tissue.
Miss Poppy, can
of the myometrium and the.
Miss Poppy,
any problem? Why my slide? Sorry.
Thank you.
Okay. I cannot move my slide. Why?
এখন হচ্ছে?
No.
Madam, please start the presentation.
I cannot move my slide.
It's moving.
বলে যান, বলে যান.
How can I say?
Madam, please keep going. We can see the slides.
No, but I cannot move here.
আপনার জগানো ফারজানাকে বলো
ফারজানা করছে ম্যাডাম ফারজানা
আপনি পড়েন আপনি বলেন
Farjana, can you go to the next slide, please?
Farzan is sharing the slide.
Okay. This is actually placenta. I created a disturb about 8 years before. And it is, all of us that what is the condition of this. Please move this slide. And this is the FIGO classification disorder. We know the grade 1, 2, 3, depending on the invasion of the myometrial invasion. And grade 3, so serious condition that is invading the uterine cells. And then 3B is extending to the bladder wall. And then 3C is beyond that. Please move, please, quickly. And this is, please quickly. And this is the clinical grading of, okay. Placenta accreta, this is ultrasonographic findings disorder. Please next. And some picture, please, going on faster, please. Yes, this is also ultrasonic finding. This is also ultrasonographic findings. This is, wait, please, 1 minute. This is the, okay, slow, please. This is the, actually, this is high risk factor. I need to mention this. Why this disorder, why you are afraid. So we know, she should know the risk factors. And direct surgical scar, accident delivery, surgical termination. Okay, objectives is that is, please, who is dealing this? Please slow. My objectives of the study, we should alert, we should reduce our litigation problem. We should know previously before starting an operation. And so this we can go complicate. We should reduce. We can reduce the complication. We can reduce the litigation problem, and we can save ourselves and the patient and all over the society. Next, please. This is actually my study while I was working as a consultant in Kingdom Saudi Arabia. You know that is very conservative country, and my study was a period of 2 years. Please next. This in this my study, I faced actually 11 complicated patients, though it was slightly periphery hospital. All patients needed blood transfusion and patients suffering from antenatal bleeding, but 77% was unbooked, and others patient needed blood transfusion to correction of the anemia. And immediate decision about the need of conservative surgery or surgical hysterectomy or vessel ligation. That is all that is planning in the OR is very complicated. And you know that conservative country, that is litigation problem is so high, and we need to discuss every time, reconsent, counseling, again reconsent, and communicate with the administration and so on. Please next. This is demographic findings of my study. For last 2 years, I faced 505 Syrian section. From that, 104 was recurrent Syrian section, and 8 patients of them is diagnosed actually before doing by ultrasonogram. And most, about 49 patients is more than 3 Syrian section. Please next. Okay, now that is actually my performance is there about to manage that 11 patients. I did total abdominal hysterectomy 2 patients, and ICU transfer needed 6 patients, and prolonged hospital stay. You know, in that country, if more than 7 days in hospital stay, too many OD problem there. Why the patient more than 7 days like this? Only 3 patients needed more than 7 days admission, and blood pressure admission, all the patients. Please go to the back, please. Back slide. That is important slide. Back slide, please. Okay, thank you. All patients needed blood transfusion, and fresh frozen plasma needed only 9 patients. No patient needed bladder repair. No patient needed internal irregularity ligation. Only 1 patient was dead due to, actually the patient came to us with irreversible shock with APS, and I did hysterectomy total. The patient was kept in ICU, but patient ultimately died. And uterine repair with hemostat. The P procedure, we know all of us P procedure. I did 2 patients. And intrauterine tamponade, that is, I did 1 patient.
And then uterine mass vessel ligation to patient. Please next slide, please. Okay, here we see that more C-gen section, more placenta activated spectrum disorder. All of us will know. Please next. Next, please. Okay, this is actually my objectives of my presentation. Where we are actually, we should reduce litigation problem, we should save the uterus, and we should reduce the morbidity mortality of the mother and the perinatal. So steps to be taken by authorized and competent person for ideal management in uncontrolled postpartum hemorrhage in war. So what I do, we should come immediately alarming to the war, and then immediately responsible consultant and the skilled person. Even then, we should call that skilled person who is well known to me, who do me proper communication with me. And even we have a tumor, but sometimes we know that person may be right, so we can call them. And then we have the bundle bulk management for the postpartum hemorrhage. So clinical, non-clinical. So all together, we should start the management urgently. Please next slide. Next, please. Actually, here a new guideline about the, if you go SCOG, RCOG, what they say about this placenta activated spectrum disorder. They said when we do the delivery, depending on the institution, sometimes someone tries 34 weeks plus 35 weeks, someone 35 weeks, but never, most possibly we do not cross the 36 weeks. How do we do anesthesia? It depends also. Particle or surgeon choice. Uterine incision, a high transverse incision usually give above the level of the placenta. Oxytocin, usually it is a tenacity or the postpartum monitoring, how you can do it. Methotrexate, usually not, nowadays not recommended, but I use 2 patients. Please next, please, quickly. Next, please. Here actually recommendation for the evaluation. It's when and how the patient is affected by the placenta activated spectrum disorder. Please next. Next, please. So in my discussion, actually, suspicion. We should suspect which patient may develop the placenta activated spectrum disorder. And as we know, there are so many limitations by the sonologists. They cannot, even in development also, sometimes failure to diagnose the placenta activated spectrum disorder in grading. So we should repeatedly communicate, and you would repeatedly request to the sonologist, please see this, I suspect this patient, please. We can go together to the sonologist to find out the findings and grading of the placenta activated spectrum disorder. We have multidisciplinary always. We should read about this, and we should, please next slide. Next, please.
Time is over. Would you please just go?
Reduce all sorts of litigation. We should reduce the litigation problem by communicating with the administrator and all the staff or management. And I prefer the conservative management. Please next. Next. So in my conclusion, we should select the high-risk group. We should select what we do, and we should rearrange everything. And please next. So the next, please.
Madam, time is over. Would you just please?
A good understanding among all colleagues, not to delay, and we should be ready so that we feel comfortable during surgery, and to be patient, and with a good surgical team to reduce all this complication. Next.
Madam,
next, thanks.
Please,
thanks. Okay, thank you.
Thank you so much, madam. Thank you so much. I would like to request Professor Shamin Fatima Nargis, madam, for making her valuable remarks on 4th and 3rd presentations. Over to you, madam. Shamin Fatima Nargis, madam.
Assalamu alaikum and very good morning. My thanks to the organizing committee to give me the opportunity to chair the session. My heartiest congratulations to the speakers for their excellent deliberation, which of course enrich our knowledge. Dr. Isma Dara really a fortune teller. We know that hypertensive disorder in pregnancy is the major cause of maternal and perinatal mortality. Need for good clinical practice recommendation are identify the risk factor for pregnancy PE and to reduce the maternal neonatal mortality and morbidity. There is no single effective screening test for identification of PE. Dr. Ismatara nicely shown us the use of gestation score that can be done by any health worker. So we can identify the risk groups of PE and we can start ecosprin and calcium in that earlier age, so halt the progress of the disease. My second speaker, Dr. Bodrunnisa Begum, talked about placenta accreta spectrum, which is a nightmare for the obstetrician and has to face horrible situation if diagnosed during the cesarean section. She, in her study in Tabuk KSA, found that 77% cases were unbooked and 80% had 3 or more C-section. Antenatal diagnosis is the main factor for a good maternal outcome. The mid-trimester fetal anomaly scan should include the placental localization also. And repeat scan, if found low-lying, repeat scan should be done at 32 weeks pregnancy to diagnose the persistent placenta previa and its invasion. If placenta parcreta is diagnosed on opening the abdomen at the time of an elective repeat C-section, where both the mother and the baby is stable, C-section should be delayed until the appropriate staff and adequate blood products are available. This may involve closure of the maternal abdomen and immediate transfer of the patient to a specialized unit. Or if diagnosed during section after the delivery of the birth, placenta should be left in situ or emergency hysterectomy may be done. Dr. Bodrunnisa very nicely concluded that antenatal diagnosis, preoperative counseling, multidisciplinary approach is needed to reduce the maternal morbidity and mortality. Thank you all.
Thank you, madam. Ladies and gentlemen, we are really sorry for the technical problems. Anyway, we are going to our fifth session, fifth speakers. She is Dr. Ms. Farhana Akhtar, working in USAID. She is Senior Technical Advisor, Monitoring Education and Learning. Her topic is Infection Prevention and Control Capacity Building in Healthcare Settings during COVID-19 Pandemic in Bangladesh. Over to you, Mrs. Farhana Akhtar.
Thank you, Dolapa. Good morning and Assalamu alaikum, everyone. I'm very happy to be here as this is a bit, different community based on my professional background. So, however, I'm going to present a few findings of a study. Can you see my slides?
Yes, we can see the slides.
Okay, thank you. My presentation topic is infection prevention and the control capacity building in healthcare settings during the COVID-19 pandemic in Bangladesh. You already know that COVID-19 triggered in 2020 in Bangladesh. So till then, more than 1.8 million positive cases are reported in Bangladesh with death toll more than 28,000. And the good news is that mass COVID vaccination is started last year, as well as the booster campaign. So the COVID-19 pandemic underscored the lack of the capacity in infection prevention and control, which we call IPC, among frontline healthcare workers in Bangladesh to treat COVID-19 patients properly to avoid the health facility associated infections. So upon request of the Communicable Disease Control of the Director General of Health Services, USAID Medicines, Technologies and Pharmaceutical Services, which you call MTEPS program, provided IPC training to 4,250 healthcare workers from 259 health facilities across the country between March and December 2020. So during that training, we also covered both male and female healthcare workers, as well as the public and private health facilities across the country. In our capacity building effort, we included IPC knowledge and practices at healthcare facilities, how to practice IPC along with trials and hands-on demonstrations on safety measures. while treating COVID-19 patients in healthcare settings as simulation exercise. Though IPC is also important in normal situation and with the non-COVID patients also. In February 2021, MTEPS evaluated the effectiveness of its COVID-19 IPC capacity building efforts in Bangladesh as we conducted training and capacity buildings throughout the 2020. So we thought that we should have some evaluations how that training and capacity building works. So the key purpose of this evaluation was to investigate and evaluate the relevance, effectiveness, and immediate outcome of the COVID-19 responses supported by USAID MTEPS in Bangladesh. The study was basically a cross-sectional study, and we used a mixed method design and follow the random sampling. From the random sampling, we selected 97 doctors and 30 nurses from 12 COVID-19 designated in that period, designated facilities in Dhaka Metropolitan City on IPC knowledge and practices. For example, Dhaka Medical College, the Medical College, and so on. We also conducted the give informative interviews from both the public and private health facilities among the doctors and nurses. So the data collection tools for qualitative was a semi-structured interview questionnaire and guidelines, and for quantitative we use the structured questionnaire. IPC knowledge and practice data were collected through in-person surveys to measure the effectiveness of the COVID-19 capacity building efforts. And to assess the relevance of the activities, we also use the qualitative data. This training was relevant for me and my colleagues because we did not have any knowledge of this novel virus. We could learn a lot from this training. This was said by a senior staff nurse of a private hospital in Dhaka while we conducted this survey. And the IPC training were necessary and relevant by mentioned by all the participants of that survey, and few of main results, or you can say findings, are IPC knowledge retention rate among the doctors and nurses was high. More than 80% of the respondents correctly answered the IPC knowledge assessment questions which they trained during the training. Key informants explained that the training improved their IPC knowledge and encouraged them to practice IPC. Among the surveyed doctors, 51% doctors and 60% nurses reported that they were able to use all their learnings from the IPC training in their practice during COVID-19 pandemic. 64% of doctors and nurses claimed that they used the national IPC guideline all the time while they're treating the COVID-19 patients in the healthcare settings. Here you can see that few of IPC practices at health facilities after the training. Doctors and nurses reported that they try to maintain triage protocols and always use face masks and wearing gowns, and also they follow and maintain the donning and doffing at the health facilities while they're treating COVID-19 patients as well as non-COVID-19 patients also. So during the survey and interviews, those participants also mentioned few challenges, as COVID-19 was devastating and the IPC was quite a bit new for us. So they said major challenges were lack of awareness and cooperation among the patients as well as among the staffs, lack of human resources, lack of treatment materials and equipment, lack of PPE, masks and gloves, as well as lack of management awareness, priority or cooperation. Though the situations improve nowadays over the period of 2021, and most of the challenges I think are already mitigated. So at the end, we can say that the findings demonstrate that the training improved reported IPC knowledge and practices of the trainees. The finding also underscored the need to focus on the challenges facing by the healthcare workers to manage patients during COVID-19, invest in more sustained IPC capacity building of healthcare workers to treat even in new normal situation, and investment in behavioral change and functional IPC committees to ensure implementation of IPC activities at the facilities is needed. So the evaluation has brought to light other important issues worth considering for future program design, including balancing emergency response with health system strengthening, ensuring the quality of work in an emergency, sustainability of emergency response interventions, the importance of systematic monitoring and mentorship. Actually, this is very short findings of that study, because there are more findings of that study, but I just took the capacity building of doctors and nurses. So thank you all. If you have any question, you can ask. Thank you.
Thank you so much, Ms. Farhana Akhtar, for your brilliant presentation and finishing the presentation in time. We are going to hear the most exciting and last topic of our session, that is learning from mistakes. Our presenter is Dr. Roshonara Begum. She is working as a senior consultant in Khagrachori Adhunik Shodar Hospital, Khagrachori, Bangladesh. Her topic is learning from mistakes. Over to you, Dr. Roshonara Begum.
Thank you. Honorable Chairperson, respected teacher, learned audience, and my dear colleague, Assalamu alaikum. Here I am, Dr. Roshonara Begum, Senior Consultant in Khagrachori Shodar Hospital, Chattogram. In my short clinical practice, I had faced some mistakes that made me disappointed, feeling guilt, and some experiences of social harassment. Out of these, today I'm going to discuss 3 cases. But in very beginning, we should know some points about medical errors. Medical errors defined as an incident when there is an omission or commission in planning or execution that leads to or could lead to unintended result. Medical errors are the 3rd leading cause of death in USA. In clinical practice, human errors are common, but these are generally underreported. Virtually all doctors have mistakes, but they often don't tell it to patients or others because facing medical error is not easy. It is very important to face these situations to learn from it so that the future errors can be prevented. Consequences of medical errors: a doctor experiences feeling guilt, disappointed, fear, and sense of inadequacy, varying degrees. My first case, death declaration of a 23 weeks living fetus. Mrs. X is near about 19 years, present as priming with 23 weeks pregnancy, admitted at night with labor pain. Within half an hour, she delivered a baby with retained placenta, which was removed manually later. Weight of baby approximately 500 grams. Baby was not cried even after stimulation and suction. Baby was wrapped by labor room ayah and sent to attendant as death. About 2 to 3 hours later, we heard a huge noise and seeing crowd in front of labor room. We were all astonished of seeing the baby was alive, and baby was sent to NICU immediately. Ultimately, baby died after 3 to 4 hours. I wondered, felt guilt and depressed. So never be hurry on death declaration. Death should be declared after proper resuscitation. Baby must be sent to NICU even after no signs of life. Low birth weight is not determinants of death and should never depend on words of labor room staffs. This is my second case, 21 weeks pregnancy misled as term pregnancy. Mrs. X is near about 32 years, obese. Junior doctor received her as second gravida with 35 plus weeks pregnancy as per ultrasonogram findings, with of history prolonged secondary infertility and features of leaking membrane for 5 days. Patient was amniotic for prolonged time and LMP couldn't be mentioned properly. I was a trainee at the time. My father was in CCU. I remembered we were overburdened 8-hour evening work. Her attendants are also forcing us for LCS as this was a valuable child. So OT was prepared for C-section. Patient was overweighted and anxious. I think in OT not examined her. My colleague asked me to do cesarean section as I was senior trainee and busy with another operation. I permitted her without any examination and had done my horrible mistakes. After some time, sister came to me and called for help. I had seen that the abdomen was opened and uterus didn't correspond with 35+ weeks pregnancy. Seeing this, I got puzzled, astonished, and shouted in OT. My shouting sound passes over OT, and this was my another wrong, immature behaviors that made me foolish after that. We closed the abdomen without touching uterus and kept file in charge with permission of my professor over phone. But in the meantime, this news was spread outside and it became juicy and tasty news in each staff of hospital. Actually, patients were 21 weeks pregnant, which was confirmed by doing another ultrasonogram on next morning. Our mentor arranged a meeting with us and hopefully all are managed properly. After a few days, patient gave birth a healthy male baby by normal vaginal delivery. And we got relieved from our guilty feelings finally. I'm still grateful to my mentor as he handled all the bad situations which was made by us and learned him that never shout in untoward situations. This is my third case. Psychological trauma of a transgender baby's mothers on table due to open discussions in front of a patient under spinal anesthesia. 24 hours primary 39 weeks pregnancy admitted for elective cesarean section due to breech presentation. 4 kg weight baby was delivered and I was confused regarding baby's genitalia, handed over to nurse. Nurse came to OT and loudly declared, baby is neither male nor female, madam. On-call pediatrician entered into OT and said this was a transgender baby, bad luck. I also made surprising sound, aha, it was really bad luck. Discussed openly with pediatrician about baby's further management. All OT staffs were whispering, patients were under spinal anesthesia and conscious regarding our conversations. After that, patient was started crying on OT. Lots of people came to see baby's gender. Hospital environment was ruined. Patient's relatives were avoiding her. They all get confused regarding baby's fate, and mother became psychic at last. Later on, I knew that the baby was handed over to transgender society. It was unexpected. So never take decision without proper evaluation of history, clinical examination, and correlation of report. Keep calm in untoward situations. Stop working in overburdened condition. Must follow how to break a bad news. Never discuss anything when a patient is under spinal anesthesia. All hospital staff should be educated properly regarding these embarrassing situations. So my take-home messages are disclose the problem faced to the patient or family very gently. Discuss the situations with the trusted colleagues. Seek professional advices. Review success and accomplishment in media. Don't forget basic self-care. Stop blame culture, which may be personal.
Thank you, Dr. Roshanara.
Or institutional. If you attention, avoid distraction, take break, careful review, stop overload.
Thank you, Dr.
And learn from mistake may reduce for patient sharing.
Thank you, Dr. Roshanara. We are just at the end of the session. I just want to invite Professor Dilip Kumar sir to give her valuable remarks on last two presentations in short, because we have already finished our time.
Thank you, Ronaldo, because and very good morning to all. Last two presenters both are very nicely and very smartly presented on the very special topics. First one was capacity building on IPC during COVID pandemic. She covered all the pitfalls and all the situation during our COVID pandemic. And last one is very important one is she mentioned some scenarios in her practical life, and she acknowledged her mistakes, and we have to learn from our mistakes if we want to avoid repeating them. Because there is no more time, so I'd like to conclude my session. Thank you once again, and congratulations to both of the speakers. Thank you.
Thank you, Thank you, sir. It is my pleasure to thank the honorable chairpersons for conducting the session so nicely. My thanks to the speaker for their excellent deliberation, which it enriches our knowledge enormously. Thanks to the pharmaceutical companies who has supported us to organize and accomplish the sessions. And lastly, thanks to our prettiest intellectual moderator of the session, Dr. Runa Akhtarullah, Assistant Professor SSMC. Thank you. Thank you all. Assalamu alaikum.
ম্যাডাম প্লেনারি সেশনটা কি শুরু করব?
হ্যাঁ, পরের এটা শুরু করতে হবে।
শুরু করে দেন। জি জি
প্লিজ।
আমাদের সেশন। জি।
Thank you very much. Call her.
Dear participants, ladies and gentlemen from home and abroad, Assalamu alaikum and very good morning to all. I am Dr. Khantaka Shehnila Tasmin, rapporteur of this session, welcoming all to this 30th International Scientific Conference 2022, organized by Obstetrical and Gynecological Society of Bangladesh. This is the plenary session where we have three honorable chairpersons, Professor T.H. Dr. Jean Conry, Professor M.A. Tahir Khan, and we also have three learned speakers, Professor Sabaratnam Orul Kumaran, Dr. Jean Conry, and Dr. Edward Morris. Surely, this is going to be the most exciting session of this day. I hope you will enjoy the session. Now, I am requesting Professor Shahi Farzana Tasmin to moderate the whole session.
Shahi, please.
Assalamu alaikum and a very good day to you all. This is Professor Shahi Farzana Tasmin, Vice President OGSB outside Dhaka. Welcome you all to this very important plenary session. I feel very much privileged to be here as a moderator. Now I would like to introduce our world-renowned chairpersons and speakers of today's session. First of all, I am going to introduce our honorable chairperson of the session, mentor of the mentors, legendary professor of gynecology, Professor T.A. Chaudhary sir. Professor T.A. Chaudhary sir is the professor of Department of Obstetrics and Gynecology, BARDEM, former president OGSB, SAFOG, BCPS, former vice president EOFOG, president FSSB, and recipient of Independence Shadhinata Padak, the highest national award from Bangladesh government. The King of Nepal decorated him with Gorkha Dakshin Babu medal. Secondly, I want to introduce our second chairperson, Professor Jenny Ann Condrey. She is the president-elect, the International Federation of Obstetrics and Gynecology, past president, the American College of Obstetricians and Gynecologists, president, the Environmental Health Leadership Foundation, and she is the chair, Women's Preventive Services Initiative. Now, I would like to introduce our third chairperson, Professor M.A. Tahir Khan, sir. Sir is the legendary professor of gynecology, and he was the former head of the Department of OB/GYN, Chattogram Medical College, and he is the founder principal of Chattogram Ma O Shishu Hospital. Now, I am going to introduce today's speakers of the session. First of all, I am going to introduce our world-renowned, famous Professor Sir Sabaratnam Orul Kumaran. Sir is the Professor Emeritus of Obstetrics and Gynecology, St. George's University of London, past president of FIGO, the British Medical Association, and the RCOG of UK. He was appointed a Knight Bachelor by Her Majesty, the Queen of UK, in her birthday in 2009. Now, I would like to request and now I'm going to request our Professor Sir Sabaratnam Orul Kumaran. Due to time difference with Bangladesh and UK, Sir will not be available in live. So we are going to enjoy the recorded session of Professor Sir Orul Kumar. Sir will be talking on CTG when to deliver. We know that CTG is a very important tool for fetal surveillance, but sometimes you get confused when to deliver or not. So I think we'll be very much delighted and will be very much beneficial from the speech of our Honorable Sir Professor Sabaratnam Orul Kumaran. Let's enjoy the recorded session. Thank you.
Good morning to those who are following this particular lecture. I'm very most grateful to the Professor Ferdowsi Begum, President of the Obstetrics and Gynecological Society of Bangladesh, for having invited me for this meeting. I'm sorry, because of the differences of timing, I'm unable to join you in person. The talk is about abnormal fetal heart rate pattern when to deliver. So when we talk about abnormal fetal heart rate pattern, we must know why we are worried about this situation, because we are concerned about the babies born in poor condition and subjected to neonatal encephalopathy and finally to cerebral palsy. If you look at the historical studies, antepartum risk factors and intrapartum hypoxia combined gives rise to 25% of these cases. And 5% are purely due to intrapartum hypoxia. So there's about 30% some intrapartum element is involved. Now, Myers did some animal experiment and showed the type of hypoxic injury can be total asphyxia. That means you occlude the whole cord, and that is called acute profound hypoxia. That causes brainstem and thalamic damage, and they present with athetoid or dyskinetic type of cerebral palsy. But if you have prolonged hypoxia, partial hypoxia, like compressing the cord a few times and carry on, that gives rise to bilateral cortical necrosis, and that gives rise to quadriparesis. But if it is prolonged partial without acidosis, it's white matter damage. But some babies will have cord compression with prolonged deceleration, and finally a bradycardia. These babies will not only have quadriparesis, but also thalamic hypothalamic dysfunction, like difficulty in swallowing, difficulty in breathing, and so on and so forth. They might need an endotracheal tube, they might need tube feeding, and so forth. So this is a typical pattern of acute profound hypoxia, as you could see from the CTG, and that will give rise to thalamic hypothalamic injury and dyskinetic athetoid type of cerebral palsy. So on a MRI, that scarring will be in the thalamic hypothalamic area, and that'll remain for life. So whether you do an MRI at 5 years, 2 years, 10 years, it'll be the same. Now this is prolonged partial hypoxic pattern. As you could see, intermittent deceleration with a rise in the baseline rate, and finally absent variability. And if it is absent variability with tachycardia and decelerations for 1 to 2 hours, the baby will get hypoxic, and the damage is bilateral cortical necrosis, and that gives rise to quadriparesis. And you can see the scarring in the bilateral cortical area. So these are the typical ones, and Henry Hackberg from Gothenburg did a study and showed that by doing MRI studies, at least 28% of term children had this damage, corresponding with Badawi studies and so on historical aspects of cerebral palsy. So we know that we can reduce the incidence of cerebral palsy by giving good intrapartum care. Now, the types of injuries seen in preterm babies are slightly different. This is from Janet Rene and her group, and this says that in preterm children, the presentation of hypoxia is periventricular leukomalacia. So that means the picture will be different. Immediately they get a ventricular and periventricular hemorrhage in the preterm period. Then the blood clots gets absorbed and the ventricle starts dilating. And as the ventricle starts dilating more and more, when the blood clot gets dissolved, then the pressure of the dilated ventricle on the corticospinal tract give rise to opposite sides. So they present not with quadriparesis, with hemiplegia or diplegia, depending on how much each side of the ventricle is dilated. Now, there's another type of injury called ischemic injury. This is paper speed of 3 centimeters, accelerative trace, and suddenly there's a bradycardia followed by a rebound tachycardia, which remains higher than the previous level without any variability or acceleration. That is called ischemic injury. And this is again another picture, some deceleration. Suddenly the baseline shifts and becomes hardly any variability and no accelerations or deceleration. And that is due to hemorrhage or a clot or something in the brain, and that can be identified very clearly. Now, obstetricians and midwives have only very few parameters to go by at birth, that is by fetal acidosis with pH less than 7, base deficit more than 12, early onset of encephalopathy between 24 to 48 hours in babies over 34 weeks. And then they should follow by spastic quadriplegia, as I shown you, or dyskinetic type. So that is thalamic hypothalamic injury or bilateral cortical atrophy. But of course, you have to exclude the other causes like coagulation disorders, infection, genetic diseases, and so on. Now, I said there should be ischemic encephalopathy soon after birth within 48 hours, and that'll be shown if you do an ultrasound by edematous brain and the ventricles becoming obliterated. And by chance, if the baby dies, then postmortem will show severe edema of the brain, which indicates that the incidence of hypoxic injury was not very, very long ago. Now, unfortunately, if you look at the CTG classification, it says abnormal CTG, then you have to deliver abnormal features with features of fetal acidosis, imminent rapid development of fetal acidosis. You have to urgently seek help, expedite birth, etc., etc. So we have to know what these patterns are. So let us start with a normal pattern with accelerations, which is an indication of somatic nervous system corresponding with fetal movement. That means this baby can't be acidotic. And the parasympathetic, sympathetic activity is shown by the baseline variability. You can measure by a bandwidth. If it is more than 5, then the autonomic nervous system is working well, the somatic and the autonomic. And then it has an active phase and goes to a quiet phase. And studies have shown that if accelerations are present, not a single baby is acidotic. So that's the first feature you must recognize. But if all the features are abnormal, tachycardia, decelerations, reduced variability, 55% acidotic, but with progress of time, more and more babies will get acidotic. The next feature to observe is, so the first one is accelerations. We call it 2 accelerations in a 15 minutes window is called reactivity. Then there should be a quiet epoch, then an acceleration epoch, then a quiet epoch. That is called cyclicity. In babies whose brains are already damaged, you might get sporadic acceleration, but you might not get this cyclicity. So the first thing to observe in a CTG is reactivity and cyclicity. Now, there are different decelerations. You don't have to worry too much about it. We are worried about decelerations which comes or remains after a contraction. Those are late or atypical variable deceleration. And the way to do that is actually, if you look at this particular graph and do a line, vertical line at the beginning of the contraction, end of the contraction, if the deceleration falls between these 2 lines, it is not going to be a problem because usually the interdeceleration interval is long. But if you draw the same lines, beginning and the end, if the deceleration outlasts the second line, they are either atypical or late. If the deceleration starts with the first line, they are atypical variable. If the deceleration starts a little bit later, then they are late deceleration. But the key feature is the deceleration outlasts the contraction. And as a result, the interdeceleration interval gets shorter, 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 and shorter. And at the same time, there will be a rise in baseline rate and finally reduction in variability. So the depth and duration of the deceleration increase, the interdeceleration interval becomes shorter, and the variability gets less and less. So that is actually how it'll happen. And this is again a typical example of acute bradycardia. So there is we call it acute hypoxic pattern. And if there is a bradycardia less than 80, the pH drops by 0.01 per minute. So this has been shown way back in 1985. There have been recent studies again by Tiva Leung and his group who also showed that the pH drops by 0.011 per minute. So here you have to deliver the baby within 15 to 30 minutes if you want to avoid an injury. So the urgent cesarean delivery, the decline is 0.011. So you have to deliver the baby as quickly as possible. This is a typical example. These are usually with sentinel events like a rupture of C-section, scar, or abruption or a cord prolapse. In 1420, there's a bradycardia. She was on oxytocin. And by the time they delivered, it was 14:55, 35 minutes elapsed. And of course, there was a rupture in grade 2. So we had to really look for clinical identification of significant cardinal events, which you had to intervene. Now, there have been studies specifically looking at uterine rupture and cesarean section, and it gives a time of 18 minutes, then the baby's condition start deteriorating. So you have plenty of time, but you must have the operating theater anesthetics available if you're giving a trial of scar. So that's acute hypoxia. Second pattern is subacute hypoxia, where the decelerations last for a longer time and returns to the baseline only for a short time. And there are a number of studies. The total deceleration area corresponds with acidemia. And so you can see these are the decelerations. The variability is saltatory. And so it's like immersing a baby underwater for 2 minutes and keeping the baby on the surface for 30 seconds. Here the pH will drop by 0.01 every 2 minutes. You can see by 30 minutes it will drop by 15 points, 40 minutes by 20 points, 60 minutes by 30 points, and then it's a bradycardia. So and then it'll drop by 0.01 every minute, and the outcome is shown by pH 6.8 and a base excess of -19 as predicted. So that's called subacute hypoxic pattern, and that should be delivered between 30 to 60 minutes. The third pattern is gradually developing hypoxic pattern, where the acceleration do not disappear, the decelerations become deeper and wider, and the variability starts decreasing with the increase in baseline rate. And once the variability disappears for 1 hour, then there's acidosis. So if you take two patterns, the upper one still has the variability, so it's not too bad. The lower one, absent variability, you should deliver the babies quickly. So these are not early, these are variable, so people don't know how to inability to interpret the trace. Baseline of 140 and variable deceleration in a sickle cell disease. The baby is not acidotic because acceleration is present. That's at 19 hours. Then at next time, 1 hour later, the pH is 7.27, the baseline has gone up, and the variability is decreasing, and the interdeceleration interval is shortening. This is another hour later, and a few hours later, 4 hours later, you can see the tachycardia of 170, hardly any variability. So one should have intervened at this point. Baby might have been acidotic, but would have survived. But they didn't do anything for 1 hour. Then the baby starts climbing the ladder and suddenly collapses and dies at this point. So I think it's quite important for us to remember that you must deliver once the tachycardia and absent baseline variability appears. The final pattern is chronic or long-standing hypoxic pattern. So there is usually a tachycardia within the normal range, but then what it happens is hardly any variability, and there are some shallow decelerations. The nervous system is blunted, so it won't have more decelerations, but very shallow. And every contraction is going to cause more and more hypoxia. So it's 2 hours later, 3 hours later, and then suddenly there's a bradycardia. So this one will have telltale signs like infection, post-term IUGR, meconium. So you can identify this baby. By 90 minutes, if it doesn't show reactivity, then you should really intervene in this case. And finally, saltatory pattern, which is actually a normal trace. They did an epidural for nearly 60 minutes. The baby's head was compressing on the pelvic floor, and there was a reduction of blood flow supply. And when they put her back, it became saltatory. And here, if the saltatory doesn't return to by 25, 30 minutes to normal, you have to intervene. They didn't intervene. And you can see there's a prolonged bradycardia, and the baby dies soon after. So what can we do? We have to think about positioning of the mother, which will improve the circulation. Maternal oxygen administration for a short time. IV fluids will be useful. Tocolysis if there are too many contractions. So there are a lot of ways by which it'll get better oxygenation. These are the four main ones. So cerebral palsy are different types, can be due to infection, that will show calcification in the brain. Asphyxia can be due to hemorrhage, but the one related to intrapartum asphyxia is about 25 to 30%. contributory. Sometimes it can be worsened by infection. And you have to think about trying to resuscitate the baby. There are other methods which are tried, which is like cooling, if there is HIE2 or HIE3, but there is controversy about head cooling now. So continuous learning is important by using packages, master classes. You can try fetal stimulation if there's a doubt about the CTG trace by stimulating the head. There are new modalities investigated, so that'll come and help us. And ECG investigations of the fetus is also in progress. And in future, it might be machine learning with artificial intelligence. So thank you very much for your kind listening, and all the best to you. Thank you.
Thank you very much, sir. Hope we have all enjoyed the brilliant presentation of Professor Orul Kumaran, sir. Now I would like to request our Honorable Chairperson, Professor T. Choudhury, sir, to make some comments on the presentation of Professor Orul Kumaran. Professor T. Choudhury, sir, over to you. Sir?
Okay. Thanks, Dr. Farzana. Now, as always, it is a pleasure to hear from Professor Orul Kumaran. Professor Orul Kumaran has been trying to popularize CTG and its interpretation by giving lectures, arranging master classes all over the world. CTG can be a good tool for interpreting the condition of the baby, provided that this is taken in conjunction with the clinical situation and it has got a solid understanding by the person who is interpreting the findings. Simply looking at a CTG chart will not possibly give you the whole information that is expected from this new modality. So CTG can be a good tool in the hand of a very well-trained person, but there is scope also of misinterpreting the findings and sometimes overdoing things. That means to deliver the baby prematurely. At one time, at the early days of CTG, the rate of cesarean section actually, rather than going down, it went up. And there are some consultants in the UK who even thought that they should throw out this CTG machine from the labor room. But as time went on, we find out as our understanding got better, we found out that this can be a very good tool. And in the hands of a person like Professor Orul Kumaran, that can be a real boon for high risk obstetrics, particularly in the labor room situation where you do not have other modalities at hand. So I think this lecture will be useful to persons who are really interested in using CTG in their day-to-day management of labor room procedures, and hopefully I think this lecture will give them some impetus to learn CTG in a better way and to interpret it better. So thanks to Professor Orul Kumaran for this excellent lecture. Thanks.
Thank you very much, sir. Thank you very much for your wonderful remarks on this presentation. Now I would like to request to invite our second speaker, Professor Jane and Country. I have already introduced Madam. Just for your kind information, time allocated for you is 18 minutes. So my humble request to you, please try to finish your talk on time. Dear audience, we know that FIGO work is built on 4 pillars, that is education, advocacy, research implementation, and capacity building. As Madam is the President-elect of FIGO, she will be talking on leadership in OB-GYN, the FIGO strategic plan. Now, I would like to request Madam to present her talk. Ladies and gentlemen, please welcome Professor Jenny and Country for her presentation. Madam, over to you.
Thank you so very much. Professor Firdausi Begum, President of the Obstetrical and Gynecological Society of Bangladesh, my distinguished colleagues and presenters today, and my dear friends. Thank you so much for inviting me to be part of a very distinguished panel where I'm going to talk mostly about the FIGO strategic plan, but I want to place a perspective of leadership because you have phenomenal leadership here in Bangladesh. I have no conflicts of interest to declare. And really, I'm going to ask you to do what you're doing. You are leaders in all aspects of the obstetric world, your hospital, community, nation, region, and the world. I want to help you understand the strategic plan for Bangladesh and share with all of Asia and Oceania and help us make the commitments. And thank you so much for talking about the pillars of FIGO. We want to grow our foundation and most importantly, say yes to leadership. So I thought I'd put the first few slides about what I call practicing leadership. First is to get involved and look at your leadership. You are involved. You're doing so much already. Bangladesh is an incredible country, an incredible member of all of our organizations. And I want to thank you and praise you for what you do. But I've got a couple rules that I always talk about when people speak about leadership. First, get rid of the future leader mantra. You are not a future leader. You're a leader here and now, and accept that you are. You may evolve as a leader. You may change as a leader, but you are not a future leader. You're a leader, period. And use that mantra. Second, say yes. When you're asked to give a talk, when you're asked to be involved in a committee, when you're asked to take on a leadership role that you're not really sure of, say yes, because you will evolve and develop and improve your leadership skills. My third is don't think of leadership as a ladder where you get on, have to climb to the top, and that's it. And if you don't take that leadership step, you're never going to be in leadership positions. No, it's an escalator where you ride a little bit. You might get off because you've got family or practice obligations, and then you get back on. So realize that leadership roles change over time and embrace that. And then finally, find your passion. Your passion may change over time, but make sure you are working on what you feel passionate about. And my passion is FIGO. So I'm going to talk about the FIGO strategic plan. I'm very proud of the strategic plan because what we put together is a view for a decade. We know that we're going to change over every 2 years in leadership within FIGO. And if we only looked at 2 years at a time, we wouldn't accomplish what we need to do. So we want a vision for a decade. And we realize that this continuum of leaders will carry on the strategic plan. We had committee chairs, we had member society representatives, regional federation representatives, trustees, and FIGO headquarters staff, all involved in developing this. We're very delighted to see how many helped and were really instrumental in just brainstorming and coming up with a vision on where FIGO should go over the next decade. We have what I call the FIGO Pentad. I tried to come up for the best term for it, but really there are 4 major areas within FIGO. Our headquarters staff and all that they do to pull us together, the trustees and the council, our divisions and committees, our ECAC, which I will develop later, but it's the Education, Communication, and Advocacy Consortium. And then all of you here, our member societies, their members, and our regional federations. That's our Pentad. Now, when we look at FIGO governance, on the one hand, we've got our traditional, we've had the FIGO officer for, since we started, 1954. So we've got FIGO president, which I get to serve, FIGO vice president, Dr. An Kihara is our president-elect, Dr. Leslie Regan, our honorary secretary, Dr. Shanta Kumari is the treasurer, and as I said, Dr. Philippe Decamp is our vice president. But this time, we've also added FIGO regional representatives. They have the pulse of the region. So we've got Dr. Muna Talak, Dr. Ravi Chandran, Dr. Basil Tarlatsis, Dr. Edgar Ortiz, and Dr. Jennifer Blake. They know what's going on in our regions, and it has been invaluable. We're only 4 months into this, and their contribution is incredible. Our FIGO Council is made up of 24 elected national member societies. They're voting members of FIGO. They advise us on how we should be. And every 2 years, we're going to elect new members. Half of the council will turn over. And I always say that by having that turnover, we increase our representatives, but that turnover also amplifies our message. Because once somebody moves off council, they're amplifying. They know what we do. They bring our message to everybody. So it's invaluable. In our FIGO headquarters, we've got Dr. Marianne Lumsden as our chief executive, and she oversees the day-to-day workings of the organization, our finances, our communications, our projects that we have running in the FIGO headquarters, and all of our conduct. It's important to have a vision statement. And FIGO has a vision that women of the world achieve the highest possible standards of physical, mental, reproductive, and sexual health and well-being throughout their lives. You're going to hear this theme often. It's our life course. How do we take women from adolescence through maturity? And that's a critical view. But one of the most important things, and this was a recommendation from our entire council, unanimous vote, we needed to immortalize the words of Dr. Mahmoud Fatala, who was the president of FIGO from 1994 to 1997. Fortunately, but unfortunately, because his words have not changed. They have the impact is still the same today as they were in the 1990s. Women are not dying because of untreatable diseases. They are dying because societies have yet to make the decision their lives are worth saving. We've not yet valued women's lives and health highly enough. 1990s, and that still is true today as it was then. So we thought that that needed to be at a very special part of our text in our strategic plan. You all can download the strategic plan easily from our website. And thank you very much for mentioning the 4 pillars of FIGO. Our foundation is our knowledge. And as you've shared today, your knowledge is incredible, and sharing that is key. That's what one of our pillars represents, education. How do we educate everybody? But you also very actively have shown the research implementation. You've had your own research project, and you've shown how we have to implement and interpret those results to improve our knowledge base, and how we advocate ministers of health, our fellow societies, and why we need to build capacity. Those are the 4 pillars that we build upon. And finally, our mission. FIGO will elevate the status of women and girls' health, reduce disparities in healthcare for women and girls, and advance the science and practice of obstetrics and gynecology through education, research, advocacy, and capacity building. That's our mission. And you live it every day. And thank you to your society. We decided we needed to focus on 4 major goals: improve the health and well-being of women and girls across their life course worldwide, enhance the status of all women, girls, and families, enabling them to realize their full potential in education, sexual and reproductive health and rights, professional opportunities, and personal well-being. Advance the practice of obstetrics and gynecology, as you're doing right now, through education, training, research, and advocacy, employing the highest ethical and professional standards, and then strengthen the role of FIGO in global health, which I hopefully am doing right now. So it's this constant interchange. We also identified what I would call 4 commitments. First is to strengthen and support the regional federations of obstetrics and gynecology. Here in Asia and Oceania, you have an incredible regional federation, well represented, and really has the pulse and the understanding of what's going on in this region, and looking forward to cooperating with them. Next, we need to strengthen the capacity of national member societies, support and empower them, so you all play a pivotal role in influencing policies in your countries. We want to encourage all efforts to empower women and girls, and to promote gender equality by maximizing the potential through education, health, and economic strategies. We want to ensure sexual and reproductive health and rights by supporting the provision of accessible, affordable, sustainable, and comprehensive health services. We want to empower clinicians as leaders. As I said, my kickoff message was your leaders. Promote the Sustainable Development Goals, disseminate current evidence in the field of obstetrics and gynecology, support universal health coverage. Who better than OBGYNs to take prevention, emergency care, and surgical care? And we want to make sure that it's preventive care, environmental health care, and access to emergency and surgical care. We want to eliminate cervical cancer and reduce maternal morbidity and mortality. But it's pretty hard. Those are pretty lofty goals. What is our path to success? As I always say, we need to have policy and advocacy on the one hand, and make sure we're talking about what our membership and our partnerships can do. And I thought I'd just take one of those goals and give an example of what we're talking about here. Let's just look at goal number 1. We want to improve the health and well-being of women and girls across their life course worldwide. Remember that lifespan approach. Well, on the one hand, in policy and advocacy, we can advocate for universal health coverage, reduce maternal morbidity and mortality, look at international development goals, work with governments, use collaborative efforts, and mobilize resources. So that's policy and advocacy. But then we have to remember our membership. So communication, capacity of our member societies, the regional federation, international partners, collaboratives, innovations, and virtual learning. And again, care across the lifespan, from adolescence through maturity. But what is planning without implementation? We have to be able to deliver what we're talking about. And that's where we're talking about communication, collaboration with divisions, committees, and our FIGO projects, creating an organizational capacity, creating a virtual university, using a FIGO platform to accomplish all of this work. So I want to now talk a little bit about our divisions and our committees, because this is new for us. We have 3 divisions, 17 committees, 185 OBGYNs devoting their time to this work, 256 members, including our associate membership. So we've got a division of maternal newborn health. We want that not to be siloed any longer. We want this robust interchange, health system strengthening, childbirth and postpartum hemorrhage, infections during pregnancy, preterm birth, impact of pregnancy on long-term health. So it's a cohesive group, all collaborating. Within the division of benign surgery, obstetric fistula, minimal access surgery, urogyne, so that we talk about the right patient for the right surgery at the right time in the right place, and safety underlying that. Division of Sexual and Reproductive Health and Well-Being. Again, the whole spectrum from conception, contraception, safe abortion, and reproductive endocrinology and infertility. We've got this continuum. And then we've got individual committees. We have safe and respectful care at our inner sphere. That's not a committee. It's just a belief that respectful care is integral to everything we do, with climate change, women facing crisis, ethics around that center sphere, women's cancer, well women healthcare, menstrual disorders, all serving as committees. 185 OBGYNs volunteering your time. Thank you. And I said I'd talk about ECAC later. It's a funny mnemonic, but it's education, communication, and advocacy. It's how we take all this information from our leadership, from our member societies, our consultants and trainees, through our divisions and our committees, and share our resources, and then share that information with, again, our regional federations and our member societies. So any of our statements, our opinions, our publications in the International Journal all come through ECAC, so that we can make sure that we're very focused in what we're sharing. We rely again here on our regional trustees because they have your pulse, and we have member society leadership. We need to strengthen partnerships across the global women's health sector. When somebody thinks of global women's health, FIGO needs to be at the top of the list when they think of it, what's going on. We are involved with the Partnership for Maternal Newborn Child Health. We collaborate with the World Health Organization and UNFPA, the International Pediatric Association, very close colleagues. We work closely with the International Federation of Fertility Societies. The Health and Environment Alliance of the European Union is a phenomenal partner because they really have a view on toxic-free environment. And then finally, the International Confederation of Midwives. We work very collaboratively with them. We know obstetrics worldwide is a collaborative practice with midwives and OBGYNs. So to summarize, it is the long history of humankind and animal kind, we're talking Darwin here, that those who learn to collaborate and improvise most effectively have prevailed. I look at the Bangladesh OBGYN Society as prevailing because you are very collaborative. I look at FIGO as prevailing because of our collaboration. And I look at this long-term collaboration with all of us. I want to thank you very much for being part of this and remind you that October 9th through 13th in 2023, we are hosting our in-person meeting in Paris. So I invite you all to participate in the FIGO World Congress. Thank you.
Thank you very much, Madam, for your wonderful talk on the leadership in OB/GYN, the FIGO strategic plan. We are really very much impressed and inspired. Thank you so much. Now I would like to request Professor M.A. Tahir Khan sir to make some valuable comments on the presentation of Professor Jain and country. Professor M.A. Tahir Khan sir. Sir, are you here?
Oh, he's on mute.
Sir is here. Sir is here.
Yeah, can you hear me now? Can you hear me?
Yes, sir, we can.
Can you hear me now?
Yes.
Yes, sir.
Yes?
Yes, sir.
Thank you very much, Professor Farjana. I would like to thank the preacher. Thank you very much. Sorry, can you not hear?
We can hear well, thank you.
স্যার আমরা শুনতে পাচ্ছি স্যার আপনি বলেন প্লিজ
Right, okay. Thank you very much. Thank you very much, Madam Jane Conry, for your superb deliberation on the importance of women's health and FIGO strategic plan to promote physical, mental, reproductive health and well-being of women throughout their lives to the highest possible standard. This presentation has highlighted that the women's life and health have been valued enough, as said by Professor Fatullah on one of the past presidents between 1994 and 1997. FIGO is the largest alliance of the national societies of obstetrical and gynecology dedicated to women's health and well-being, can bridge between regional societies, forming a global network of common policies to promote the health of women, girls, and newborn. You have highlighted this so nicely. So FIGO's work is based on foundation of 4 pillars. These are education, advocacy, research, implementation, and capacity building, and purposes for long-term goals, 4 long-term goals: improving health and well-being of women, enhances the status of women and girls, advances the practice of obstetrics and gynecology through FIGO's 4 pillars mentioned as education, advocacy, research, implementation, and capacity building. And finally, strengthening the role of FIGO in global women health. So you have very nicely actually elaborated all this. I would like to thank you very much for your beautiful speech.
Thank you so much.
Thank you very much, sir, for your wonderful comments on this presentation. We are at the end of our session almost. Our third speaker is Dr. Edward Morris. Now I am going to introduce our third speaker. Dr. Edward Morris, he's a consultant in obstetrics and gynecology in Knockford and North University Hospital NH Foundation. He is the Vice Chair, Academy of Medical Royal College, 2022 date. Vice President Clinical Quality, RCOG, 2016 to 2019. East of England Fellows Representative, and he is the Chairman of British Menopause Society. He is the member of BMS Council and is the trustee of BMS and Women's Health Concern, and special interest in advanced management of menopause, provision of tertiary level endometriosis service, quality improvement, patient safety, and is the coordinator of journal Post-Reproductive Health. Saud will be talking on HRT and breast cancer. Dear audience, we know breast cancer is the most common carcinoma in the women, and the risk of the breast cancer is the most common serious complication associated with MHT. Sir will not be able to join with us. Right now, we are going to enjoy the recorded presentation of Professor Dr. Edward Morris.
Hello, everybody. My name is Eddie Morris, and I'm President of the Royal College of Obstetricians and Gynecologists, and it's indeed an absolute honour to be invited to OGSB to give a talk at this Congress. I'm very sorry I can't be with you physically, but at least we have the virtual presence to help me get my message across. I hope you enjoy the rest of your meeting. So I'm here to talk about breast cancer and hormone replacement therapy. Now, you're likely to know that in the UK and in most of the Western world, the lifetime risk of developing breast cancer is in the region of 1 in 7 women. So 1 in 7 women will develop breast cancer. But the risk of dying from breast cancer is a lot less. It's about 1 in 32. And that needs to be borne in mind when we're talking about the risk of breast cancer and the impact that it will have. When we look at the overall effect of modern healthcare on the mortality from breast cancer, you can see that this has continued to decline since a relative peak in the mid-1980s. And that's with early diagnosis and also with modern treatments, as well as the national screening program. The survival in the UK, though, has increased quite significantly. So the overall survival for breast cancer, as you'll see here, is about 76% over a 10 or more year period. And those are figures for England. And the age when breast cancer is diagnosed is 60 to 69, when the survival is highest. And you'll see that the survival has actually doubled in the last 40 years. And so that's a very interesting statistic to look at and to consider. There's some common breast cancer statistics that some people may be unaware of. So the preventable cases, about 23% of cases in the UK are considered preventable. And when you look at these two modifiable risk factors, obesity and alcohol, they actually have quite a significant impact. And the causation of radiation is actually pretty low, but that's about 1%. But when we're dealing with things in the menopause, and especially with women, when we're explaining risk, this slide shows, to me, it's a very old slide, but it shows the uphill struggle that we have when we're explaining risk to women. So when you ask a woman what she's likely to die of, what she thinks she's going to die of, in this study, the vast majority thought they were going to die of breast cancer. But the actuality really is that not many women are actually going to die of breast cancer. In this year, it's about 4%. But you can see here that there is a skew between perception of risk and the actuality. And that is important when you're considering what may be going through someone's mind when you're going to talk to them about breast cancer and anything that could modify the risk. The link with body mass index I've alluded to, and that's pretty clear. If you have a raised body mass index, and the EPIC study has shown that if you've got a BMI of greater than 30, then your risk of breast cancer has a 31% excess risk. In the Million Women study in the UK, that showed in women of a 54-year-old age group that if you're postmenopausal and have a rise in BMI of 10 points, that's quite a significant rise, that the breast cancer increases by about 40%. And that was statistically very significant. And the Nurses' Health Study, again, that shows looking over a longer period of time that if you gained weight of 25 kilograms, your risk increased by 45%, and 10 kilograms, it increased by about 18%. And if you'd never used hormones and you maintained a 10 kilogram loss after the menopause, you can see there's actually a reduction in risk of just over 50%. So that's very interesting data. And then when you look at the age of obesity and breast cancer incidence in postmenopausal women, you can see that the older you are when you are obese, then that relative risk increases when you compare against never users. And this is a relatively recent study. And we know as gynecologists that the incidence of several different cancers is affected by obesity. This is a study from the BMJ in 2007, but shows very nicely, you go from BMI of 20 to 35 on each of these graphs, you'll see the incidence of breast cancer in the postmenopausal population increases. It probably doesn't increase in the premenopausal because actually there are other hormones around at that time. But in the endometrial malignancy group, you can see, and I'm sure you experience that in your day-to-day practice, that as BMI rises, and so does the incidence of breast cancer. But I'm here to talk about HRT, and certainly the most significant thing that affected menopause and HRT prescribing was the Women's Health Initiative in 2002. And the press release from the study said that hormone therapy study was stopped, the WHI study was stopped due to the observed increased breast cancer risk. And this was certainly a shot that was heard all around the world. And that was Bob Langer's comment in June 2012. The Lancet press release at the same time said that because there was a substantial increase in breast cancer risk from combination hormone replacement therapy, that women should and certainly that had a significant effect on prescribing in the UK. And we look at Scotland as an example. You see in 2000, 2001, prescribing was pretty good. And then it pretty much dropped off a cliff after the publication of the WHI study. And we can see here that actually in 2002, there were lots of headlines like this about saying that HRT was actually dangerous for women. And then when other studies came along, there was press about the use of HRT. And in 2005, I think women were starting to say, well, we're a bit confused, we're hearing mixed messages. So why should we be rejecting and sort of give us facts, but don't give us fear? And these two articles were in the same version of a UK newspaper. So people are getting confused and they were feeling scared about whether they should be on HRT. So fast forward to 2012, and that was when some reanalyses of the WHI study were published. And the conclusion, certainly in the menopause fraternity, that actually there were questions as to the methodology of the WHO conclusions that they were taken, and also the Million Women study. And then there was a lot of discussion about how women suffered in those 10 years since the WHI study. And certainly when you looked at some of the publications, that actually the estrogen-only arm of WHI, so women on estrogen only, had a reduced breast cancer risk. And that was made at the time. And so a lot of people felt at the time there's a big backlash to say that actually HRT should be considered because the impact on the breast is a lot less than was previously thought. But still at the same time, there were detractors who felt that the HRT was still influential and should be considered. And this was all in the press and all around about 2012 in the UK. So that was there was a lot of battling going on. So when we look at the Women's Health Initiative and the effects on breast cancer, the group themselves have shown over the years that there's been some shifting in the risk calculations. And this is partly through following the patients through the study, but also re-looking at the data. And certainly if you look straight at 2002 against the 2013 publications with regard to risk of breast cancer and break it down by age, you will see that the younger women, when they're taking estrogen and progesterone, they have an increased risk of about 20%, but actually not achieving statistical significance because they're not grouped together. But as age goes up, as you would expect with the biology of breast cancer, that increase in incidence goes up. But again, because it's broken down by age, we're not seeing any statistical significance. So is it necessarily as relevant as we might think? And as I said, the estrogen-only arm did show that there was a reduction in breast cancer. That's about a 23% reduction. And that's very significant. And that's the incidence of breast cancer, but actually a 63% reduction in deaths from the disease. But still the authors were keen to point out that that doesn't support a prescription of HRT to reduce the risk. When you're looking at more widely prescribed versions of HRT in Europe, so that's estradiol and not conjugated equine estrogen, we can see here that in this big study, which is a Danish study looking at over 2,000 women, randomly allocated to HRT in an open label style, but also some women who chose HRT. And that was actually again stopped early after 10 years, mainly through the publicity rather than adverse outcomes. If you look at the effects of HRT on various different outcomes here, you can see that the only one that seems to get statistical significance is if a woman is under 50 and is on HRT, then she is protected because her risk falls by about 70% and also achieves statistical significance. Most of the other findings do not achieve statistical significance. The overall mortality from breast cancer is reduced statistically by about 50%. But you see everything else, although it appears to be mainly to the left-hand side of the line here, do not reach statistical significance. So again, this is encouraging data. But it all comes down to the practicality. What will you quote? Because as I said at the beginning of the study, explaining risk is very complicated. So the WHI initially said there's a 26% increase with combined HRT, and that's in excess of 4 per 1,000 women over 5 years use of HRT. But again, it's very difficult to explain the mortality issue. But when you're counselling women, you mustn't forget that the incidence and mortality from breast cancer is affected by alcohol and obesity. Now in the UK, the NICE guidelines was produced, and these are the figures that we were given. The first time ever that we saw background figures of HRT, and this is per 1,000 women aged 50 to 59 over a 7.5-year period. So coronary heart disease, the baseline 26.3, stroke 11.3, but breast cancer, interestingly, 22.5. So I round that up to women and I say the baseline's about 23. And on its own, you have 4 fewer breast cancers, and you give estrogen and progesterone for that 7.5-year period, that's 5 more breast cancers. And that helps women really contextualize the position. It has been very useful to me since it was published. The guidelines are currently being updated as we speak. More interesting and more recent data published in The Lancet has shown the effects of duration of HRT on breast cancer incidence. And this is from starting HRT at 50 and then taking it for 5 years or 10 years up to certain ages. And you'll see that, as we know, the older the woman, the greater the relative risk, and you see the duration effects of taking hormone replacement therapy. And you see the difference between cyclical and continuous combined HRT. Doesn't seem to be a great difference there. But also you see the effect with estrogen only. And it shows that in the younger age groups, that effect is less than in the older age groups. And then if you compare never users of HRT, the effect of body mass index, again, as I said earlier, the increased BMI shows that increased effect, again, it's a compound effect with age, which is obviously a very significant thing to consider. But I commend to you the publication of the British Menopause Society Fast Facts, and these are relevant because they're quick and easy to use as clinicians. They're online and they're free to use on British Menopause website. And when you look at the risk of being diagnosed with breast cancer, remember I said at the beginning, it's the incidence that's important, not necessarily the mortality. So if a woman has a low underlying risk of breast cancer, so that's most women, the symptomatic benefits of HRT use for up to 5 years will exceed the potential for harm. But where risk is estimated to be elevated, the degree conferred is considered small. So you do need to consider the background risk of the woman. Most women won't be diagnosed with breast cancer as a result of their exposure to HRT, and that's a fact. So 23 per 1,000 is the background risk. If you increase it by, say, 10 per 1,000 to 33 per 1,000, still most women won't be diagnosed with breast cancer, well over 900 women. In women who got premature ovarian insufficiency, years of HRT exposure should be counted from the age of 50 and not the age at which HRT is commenced. And that's because a woman before the age of 50 who's not had a premature menopause will have many more hormones in her body than someone who's over the age of 50. The risk is not increased in overweight or obese women who use HRT, their risk is increased by the fact that they have a raised body mass index alone. And HRT doesn't really add to that risk from the evidence that exists. Unopposed estrogen, that's associated with little or no change in risk. There's no evidence of a dosage effect, and the risk is not increased with vaginal estrogen at all. And the risk may be increased in past users of HRT. One has to consider someone's past use of HRT. Now, with combined HRT, as we said, that there is that duration-dependent increase of risk. So if you take it for longer, the risk increases further. There's a greater risk than sequential HRT when you have continuous combined HRT. The absolute excess risk is small, though. It's maybe a maximum 10 additional diagnoses per 10,000 women aged 50 to 59 with up to 14 years use. And you should weigh that against the risk of endometrial cancer, which again is significantly reduced by long-term continuous combined HRT. And the risk may be increased in past users. So there's a good table there that gives you the absolute numbers. I'm not going to go through those now for time reasons, but they are there so that you again can put into context the effects of considerable alcohol intake and its influence on breast cancer versus the use of HRT. Mortality, so in women who've got population risk, the overall mortality risk benefit ratio favors both unopposed and combined HRT, but unopposed HRT may be associated with a reduction, and combined HRT is not associated with an increased risk, so it does not change the background risk of a woman. Now, what about women at increased risk of breast cancer? Well, most women, so that's over 90% of the population, have a low lifetime risk of breast cancer, and there's no strong evidence for an additive effect of HRT on that risk of diagnosis of women at an elevated personal risk. So whether that's family history or she's already had a benign breast condition diagnosed. So the risk conferred by HRT will be dependent on the baseline risk in these higher risk women, but we don't really know that. We don't know that on an individual basis. So we suggest that we being the British Menopause Society, suggest you avoid HRT in women at high risk, unless it's BRCA1 and BRCA2 mutation carriers who've had a prophylactic oophorectomy. And there, add-back HRT can be used for symptom management until the age of 50. And after that, then think of lifestyle and non-hormonal changes. But high-risk symptomatic women at an elevated risk of breast cancer should be referred to menopause specialists. So this, in the UK, we don't think is where people should be working on if they're not menopause specialists. So in summary, with HRT, the evidence supports the efficacy of HRT, as we know, on vasomotor symptoms, cognitive improvements, and other menopause symptoms. The risks, well, venous thromboembolic disease, there's clear evidence, and there's also clear evidence of a very small increase in the incidence of stroke. The evolving picture still is on breast cancer risks and cardiovascular disease, and as I said earlier, NICE is commissioning a refresh of its guidance, so keep your eyes out for that. Another more recent publication from the British Menopause Society and Women's Health Concern is updated recommendations on HRT use in menopausal women, and that's a very thorough explanation of the situation, not just breast cancer, but many other areas of menopause, which I know that you are interested in. So I hope you found that talk interesting. This is a photograph of the inside of the new college, the RCOG in London. I hope very much I'll be able to travel and see you sometime. And if you're coming to London, please let us know. We'd love to see you at our new home. Thank you for listening, and I hope the rest of your conference indeed goes well. Thank you.
Thank you very much, Dr. Edward Morris, RCOG, President RCOG, for your wonderful and updated presentation on different aspects of HRT and breast cancer. Now, I would like to request our chairperson, Dr. Jane Ann Country, to make her valuable remarks on the presentation of Dr. Edward Morris. Dr. Jane Ann Country, Madam.
Thank you, my distinguished colleagues, and thank you, Dr. Eddie Morris, for such an incredible talk, enlightening and brain-filling, if I can say. I appreciate starting with the Women's Health Initiative. For those of us who are old enough to remember WHI publication and it coming out, it was a game changer for sure. And then the ensuing research that's helped us almost peel the levels apart, and you've done that so eloquently for us. You've peeled all those layers so we understand it very much better. I do appreciate you pointing out most women, when they have a diagnosis of breast cancer, feel like they're going to die. That it's just the diagnosis and the fear alone. So being able to put that perspective overall and how successful we've been in treating breast cancer, I think was a very helpful start to the entire program. And then I very much appreciate your analysis of estrogen alone, unopposed estrogen and progesterone, the cyclic and the continuous, because all of those different modalities are what we face when we're prescribing for women. I think the age effect and certainly the complications and the perspective of obesity, of underlying cardiovascular disease and other risk factors really makes it a very important studies to analyze. And I think all of us look forward to the new NICE guidelines that are going to be coming out. The Danish study was very enlightening. My take home message there was 5 more and 5 less, depending on what we were doing. So it's one of these situations where having a close discussion with our patients is probably the most important step that we can do. Having the background information and then being able to place an individual's risk factors in perspective for them is really critical. So again, Dr. Morris, thank you for a very enlightening talk. And certainly we have evolved in our knowledge from the Women's Health Initiative in the early 1990s. Thank you, everybody.
Thank you, madam. And this is the time to say goodbye on behalf of me. And now I would like to request Dr. Shehnila to propose vote of thanks. Dr. Shehnila Tasmin, over to you.
It's my pleasure to thank the Honorable Chairperson for conducting this session so successfully. My special thanks to the speaker for their excellent deliberation, which has enriched our knowledge enormously. We are very much inspired by their presentation. And last of all, thanks to the pharmaceuticals companies who have supported us to organize and accompany this session. That's all from the plenary session, and thanks all for the kind participation. Thank you all for patient hearing.
Dr. Jin, hi. Kondi, are you still here?
I'm here.
Yeah, so welcome. You are looking so fresh, and I think it's almost 11 p.m. Thank you. Thank you for being with us. Yeah,
thank you.
It's really rewarding. And you see this, I don't know whether you can see this. No, for the background. This is the
I do. Yes. Yes.
This is the FIGO monk. This is for the PPIUCD project. This is the FIGO IUCD project. Yeah. So it's rewarding. And I must be thanking Professor T.A. Chaudhary sir and M.A. Tahir Khan sir for excellently chairing the session as usual, of course, sir. And this is always inspiring. Dr. Kajunuri is here. We had the great talk from Professor Arun Kumaran and Dr. Maurice as well. And Jenny, you were really a leader. We are really inspired. And
you are, so I won't say more. You are, Dr. Begum. You are an incredible leader for Bangladesh, and for all of us, and for women in medicine. So thank you.
Our great teachers always lead us. And, you know, this strategic plan of FIGO, it's mind-blowing. I think we need to follow the structure you meant. It's fantastic. Thank you.
Thank you.
Thank you. Sir, কিছু বলবেন স্যার টেজুদি স্যার and that এটা আনমিউট করে নেন স্যার।
I've got nothing to add. Only thing, this is an excellent, refreshing and rewarding session. Particularly, I was impressed about the current activities of FIGO, about which many of us actually is not completely aware. So thanks, Jean, for clarifying the activities of FIGO. And Edward Morris, I think, demands great congratulations from all of us for trying to clarify some of the points raised by whether or not to use HRT. This is still a burning issue, not completely clarified, but he has tried to make some inroad with tangible data, and I think we can now reach a little more towards our aim of whether or not to prescribe HRT in women, which HRT to prescribe, and how long to prescribe. So these are issues that will be coming again and again, and Maurice has taken a great step in clarifying some of them. So thanks again to all the speakers.
Thank you. Tarkan sir কিছু বলবেন স্যার? আমাদের একটু সময় আছে. We have got 5 minutes time before the next session, so there is a tea break.
আনমিউট করতে হবে, আনমিউট করে নিতে হবে.
Tarkan sir unmute করতে হবে. And Ginny, you were seeing the background. That was the place we are supposed to be doing the program.
Darn.
This was an excellent session, actually. I have enjoyed it thoroughly. All the 3 papers were quite nice, actually, and very learning materials are in them. So, and my thanks to Jane Connery, who is still awake, actually, to listen to us. So, Professor T. Chaudhary and all the speakers, the moderator, and the rapporteur. Thank you all very much.
Thank you. Thank you. And Jeannie, you will be seeing a big contingent going to Paris if the situation permits. Yes, of course.
We're hoping. Thank you.
Yeah, we'll have a special meeting if time permits with you there.
Oh,
thank you. And warm invitation to Bangladesh anytime.
I would so love that. I would very much. Thank you.
Thank you. Thanks a lot. And I think there are 2 persons from Bangladesh now in your team, 3 persons, I think, in your committees.
Yeah.
Yeah. Last night, I think you had this meeting with Well Women's Committee, and
we
our
did.
secretary was there, I think, Dr. Gulshan.
It's the first time having a Well Women committee. So they're going to really intersect with everybody, but look at care across the lifespan, adolescence through maturity. And certainly menopause discussions will be an important part of that. So having today's talk was really helpful. I know that's going to be one, and breast care is going to be another part of it. Cardiovascular, what do we do about cardiovascular disease? We don't recommend bone health discussions as much within FIGO. So looking at some of those that really are our day-to-day visits with our patients and what they need, and getting women to believe that they need to take care of themselves with preventive health. And I think that's an important message we need to get across.
Thank you. Thank you so much.
Dosiapa, can I say one thing?
Yeah, of course. You introduce yourself and talk.
Morning to everybody. I am Professor Farna Dhawan, President-elect OGSB. Yeah. I just like the way Jean Madam started the presentation. I think we also have to learn from her. I was astounded. I was seeing myself, all of us in the screen. She was just showing us as leaders. I think that is.
I was also confused what's happening.
I thought, was it by mistake? Then I saw that, yeah, it was her presentation. So, Madam, thank you so much. And thank you so much for your brilliant presentation.
Thank you.
Can we start the next section?
Dr. Corney, Professor Gulshanara, your team member, Dr. Corney.
Hi. Saw you yesterday. Yeah.
Very nice looking with our background for our conference.
That's my kind of environment.
Zinat, you can introduce yourself.
So nice.
Oh, thank you, madam. Thank you, me, Professor Zinat. Hi, everybody.
She's Chair Scientific Committee. She's leading us. Thank you, Ginny. It's so nice. We're like a family, so we'll keep this spirit together. Yeah.
Thank you.
Thank you.
May I say something?
Yeah, of course, Samina.
Hi, Dr. Chaudhary.
Hi. How are you, Kandi?
I'm
and
good.
It's a very brilliant presentation, and as a whole, this is a wonderful session. All 3 presenters are doing well. Excellent.
Thank you.
Okay.
Madam, we should go for the next session, madam.
Yeah. Thank you. Thank you, Jeannie.
so much.
Thanks to all.
Okay.
We'll start next session.
Thank you. Au
Thanks.
revoir. Thank you.
Firdausi, I'd like to thank all of them.
Please
Can
start
I
the
speak?
next session, please.
Okay.
Thank you, madam. Thank you.
Firdausi, I'd like to thank all of you, including our foreign delegates,
Of
those
course,
who
ma'am.
has given a very good learning to the morning. This is really nice day for us. Thank you, Colonel. Thank you, all, everybody. I'm Latifa.
Uju.
Please, moderator, start the session, please.
Assalamu alaikum, ladies and gentlemen, and a very good morning. This is Dr. Lutfunnaha Shompa. Welcome you all to the Suffolk session of 30th International Scientific Conference of OGSB 2022. The theme of the session is PPH bundle. We are highly honored to have 3 chairpersons among us and presentation of 4 speakers from home and abroad. Now I'd like to hand over the mic to Professor Dilruba Zeba to moderate the session.
Hello. Hello, Assalamu alaikum. Thank you, Dr. Shompa. Am I audible? Hello.
Yes, madam, you're audible.
Yes, you are. Yes, you are.
Hello.
আমরা তোমাকে
Yes,
শুনতে
madam,
পাচ্ছি
we can hear
দিলরুবা,
you.
শুনতে পাচ্ছি।
We can hear you, madam. We can hear you. Please proceed.
Thank you, madam. Thank you, Dr. Lutfunnaha Shompa. We know this session is for 1 hour. Respected speakers, you have 13 minutes for each presentation, and you are requested to complete your presentation in time. Dear audience, if you have any questions, please give it in the chat box, which will be discussed at the end of the session if time permits. We have 3 honorable chairpersons in this session. It is my pleasure to introduce them. First of all, Professor Firdausi Begum. She is the president of OGSB, Department of Obs and Gynae, Ibrahim Medical College, Bardem Hospital, past president Suffolk, member PAG for Quality Improvement Secretariat, Ministry of Health and Family Welfare, Bangladesh, Focal Point Bangladesh, FIGO Initiative for Prevention of Unsafe Abortion, PPH Bundle Project. Thank you, madam, for chair the session. Our another renowned chairperson is from Sri Lanka, Professor Rohana Hatathua, Chairman, 9 Oils Care Mother and Baby Hospital, Secretary General AOFOG, Vice President Suffolk, and Country Representative Aspire. We have another chairperson with us, Professor Rohima Begum, ex-professor of Obs and Gynae, Bardem. With the kind permission of the chair, now I want to start the session. Our first presentation is from Thomas F. Berg. Sir is the Chief of the Division of Global Health Innovation, Massachusetts General Hospital, Associate Professor, Harvard Medical School. Dr. Berg has led a research program focused on PPH for last 12 years. Sir, it is your time to present your paper on overview on the PPH bundle. Thank you, sir.
Hello, can you hear me?
Yes, sir, we can hear you, sir.
Yes, we can hear you.
Oh, good. Let me just see, how do I get the screen sharing to come back? Resume. There it is. Okay. Can you now see the screen, everybody?
Yeah, clear.
Yes, sir.
Wonderful. Thank you very much. Thank you very much for inviting me. It's such an honor to be here with you. And this is such an important topic, and this is such an important conference. When I went through the entire program, wow, this is just truly, truly special. And it's really wonderful to be here with you. What I'd like to talk to you about over the next 13 minutes is that of an introduction to the PPH bundles. And many of you may have heard the whole notion of the PPH bundles, and I'm going to just take us through a little tour of what that means. I'm trying to go forward and it won't go, there we go. Now I'd like to start and just remind us all the reason we're here at this conference, the reason we're focused on maternal survival and maternal health, and especially when we look around the world beyond our own hospital, beyond our own home, we must be reminded of this, and that is we're committed to women worldwide, every walk of life, because we believe that all human beings are born free and equal in dignity and rights. And we also believe the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being. So why bundles? What do we mean and what are we talking about? Well, over the last, really now 2 decades, facility-based care is progressively becoming more the norm. Yes, indeed, there are still plenty of women on earth that deliver at home or deliver in facilities that are not of the quality care that we all would wish for. But it's becoming more and more common that women are finding their way to facility-based deliveries. But what have we learned from this? We've learned that there are delays in identification when a mother is in trouble, delays in intervention, and that there are disorganized use of interventions. And this really is what calls for an integrated, comprehensive, organized approach. So what are care bundles? Patient care bundles are a limited set of interventions for defined patient populations and care setting. So instead of the large algorithms that we are used to, these charts with arrows going all over the place, these are really discrete, make it much easier for us to remember how to move forward and save a woman's life. They increase quality of care, they increase adherence to guidelines. Every patient should receive all elements of bundles. They should be simple, but unless they're not indicated. So common sense is not to be eliminated. Target compliance is at least 95% of all the components of a bundle are actually executed. And they are based and grounded on quality, science, and evidence. And these for PPH bundles are based on the 2012 WHO recommendations. So patient care bundles differ from a package or differ from a guideline, and that compliance is measured for every patient. And it really focuses on a holistic systems-based approach to providing emergency quality care to a woman. It inherent to being a bundled set of clinical interventions includes teamwork, communication, monitoring, quality assurance, those very pragmatic aspects of what it means to provide a systems-based quality care. We move away from the complex algorithms, but it's not a magic bullet. It depends on behavior change and the health system adapting and adopting the interventions. As we all know, changing human behavior is never easy. Here's actually a picture of, this is, you may recognize some of these people, but these are really what WHO handpicked a group of individuals to really work hard over the course of a year. And then in 2017 came together at Harvard to identify what are those scientific principles that are key, that are cornerstone for PPH, and then develop the bundles off of those. So not to go into all the details, but it was a very rigorous pathway of using science. There was initially a literature search Then there was a very specific form of using evidence, using the grade criteria and a framework. And then there was a first set of virtual expert consultations, and then followed up and eventually over the course of a year by a final agreement on what the bundles would be. So what did we learn? We decided that Amstel is actually a bundle, but does not require being renamed. That's silly. Everybody on earth know what active management of the third stage of labor is. So uterotonics, controlled cord traction, uterine tone assessment, and late cord clamping, those are all part of the bundle of Amstel. Although WHO made sure to remind us all to de-emphasize the controlled cord traction. The two PPH bundles that were developed include first response bundle, which is comprised of uterotonics, isotonic crystalloids, starting in IV essentially, and tranexamic acid and uterine massage. Then the second bundle, or was called response to refractory postpartum hemorrhage bundle, included compressive measures such as aortic compression, bimanual uterine compression, use of uterine balloon tamponade, and then the NASG. And it should be kept in mind that additional doses of uterotonics, tranexamic acid and fluids would be continued. Now, the first response bundle continues even if you move on to the second one, or the response to refractory postpartum hemorrhage bundle. Our computer is stuck again. There we go. So here is a card that many of you have probably seen. In this card defines the bundles. You can see Amstel at the top, call for help, assemble a rapid response team. And then there are these four components: the IV fluids, uterotonics, tranexamic acid, and uterine massage. Those make up the first response bundle. You don't have to think, here it is. There are, of course, supportive measures. This is not all and everything within that first response bundle. Obviously, we need to treat lacerations. We need to examine the woman. We need to empty the bladder. We need to empty the uterus. And then should those fail, and they don't fail 90% of the time, but should those fail, then we move on to the response to refractory hemorrhage bundle, compression, balloon, and anti-shock garment. Now, implementation models. This is really, really important. And this really is what makes bundles work. It's not just a set of clinical interventions that you know, but it includes implementation modules of leadership, communication, and teamwork, network integration, facility readiness, compliance, and quality assurance, and then quality improvement. I don't know why I'm having so much difficulty. There we go. So the implementation modules, the first one is leadership, communication, and teamwork. That is probably self-evident, but unless you practice and actually put it into form, it doesn't happen. So identification of a team leader, forming a rapid response team, accountability to a team, everybody knows their role. Communication is paramount. It's surprising without practice and without identifying communication strategies, we don't do very well. And communication means with each other, with patients, with family, within and across teams, and then also across institutions. And we always do all of this with respect and compassion for each other and for our patients. Network integration. What do we mean by network integration? Here's actually a diagram that Jurker Lillestrand, quite famous, who most of you I'm sure know. he put this together based on work that he was doing in Cambodia. But it's really nice because it tells us and it reminds us that as leaders, and I would say every single person, all 60 of you on this, in this meeting right now, are leaders. And it's really incumbent upon us to remember something, that we care about not just the woman in front of us, but we care about, and we have love in our hearts for, and we have vision in our mind for the health and safety of women that are in the waiting room, women that are at a different facility that is connected to our facility, a woman in our region that is in trouble, that is in labor. That woman is somebody we care about. And so we have to act. And how do we act to care about that woman? We make sure that we provide mentorship to those that we can connect with. So here you can see the referral hospital is connected to the health centers, and those health centers are connected to the community. And what does connection mean? Connection means that the health centers look to you for guidance and advice. They're not afraid to call you. And there's a synergistic working relationship. You actually get together and learn from each other, teach each other. We can learn from those that are at small centers. We are so used to having everything at our fingertips at times that we forget what it's like to be in a more difficult circumstance. But we need to help each other. Facility readiness. What does that mean? Facility readiness means that we have the equipment necessary. And I've seen really interesting over the last few months, PPH corners, certain PPH kits, various kits that are out of plastic. People make these wonderful kits out of cloth that can be folded and brought into an ambulance, or you can run to a different part of the hospital with. But whatever in your system is necessary to make sure that you have with you the commodities necessary, that you have a plan in place for transportation, a plan in place for data management, that you have your facility is ready to take care of a woman with a variety of different emergency conditions. Compliance, quality assurance, and quality improvement. And I can tell you, I'm right there with you, that as a doctor that has been caring for emergency patients now for over 30 years, thinking about quality assurance and quality improvement is not often the most interesting time of my week or of my day, but it is very important. That's how we learn. We learn how to plan, to do, to study, and then to act, and how to improve what we do. The only way we can do that is if we get data. Now, I put these together. On the right, you see the clinical aspects that you all are expert at, but putting them together in a simplistic fashion. Those married together with the human behavior of leadership, communication, and teamwork. Network integration of your network. Making sure your facility is ready. And then using quality assurance and data for quality improvement. This holistic package together is really what we mean when we talk about the PPH bundle approach. And I'll leave you with, just think of this approach. This actually now, when you start recognizing this platform, can certainly extend far beyond PPH emergencies, right? You can imagine how this can apply with some minor tweaks to hypertension of pregnancy, sepsis, obstructed labor. Really, the opportunity for the arc of emergency care applies here. Now, I look forward to, we'll see in these next few talks, some examples of some details, some examples of where it's implemented, and then some key components of the PPH bundle. With that, I'll stop. And I thank you so very much for welcoming me here. And I wish you a wonderful, wonderful rest of your day and week.
Thank you, sir. Thank you very much. Thank you for being with us. Now, I'm requesting our respected chairperson, President OGSB, Professor Ferdowsi Begum Madam, for some remarks on this presentation.
Thank you. First of all, I must be welcoming the chairpersons, especially President Safok, Dr. Rohana, to be with us, and also Professor Rahima Begum, and Dr. Burke, old friend of us, working for some times. Thank you for being present at the odd hour of your place. At the same time, presenting the PPH bundle in a nutshell, but in a very bundle way. So we had the idea about what a bundle is, how the PPH bundle is being formed or classified, and the way of managing it in not only clinical bundles and also in non-clinical bundles, both of which are very important. And as we know, that as the evidence say, that putting these non-clinical interventions into bundles has basically changed the face of management of PPH, and thousands of women dying somewhere in the dark at the dead of night has been reduced by the way it has been placed. And I hope we can institute, we have started this in Bangladesh, but we're going to expand this soon. And we are taking this up in Suffolk region as well under the leadership of Dr. Rohana. And of course, Dr. Burke, you are in your institute, this innovative institute of Massachusetts General Hospital, helping us a lot, especially this ESMABT and all this. So thank you, Dr. Burke, being present here and inspiring us. Thank you so much.
Thank you. Thank you, Madam. Now, I would like to call upon our another respected speaker. She is Professor Farhana Dewan ma'am. She is the President-elect OGSB, Deputy Secretary, Suffolk. She contributed a lot in the government job, and after retirement, now working as a head of the Department, Gynae and Obs, Ibn Sina Medical College. She is working actively for a long time in OGSB. Her topic is on role of tranexamic acid in prevention of PPH. So now, ma'am, please start your session.
Thank you, Dr. Dilruba Zeba. So I need to share my screen. Can you put off the screen share? Shamrul? Yeah, thank you. So can you see my screen, Dr. Zeba?
Yes, Farhana.
Thank you, madam. So dear audience, good day to you all. I am really delighted to be able to present in this esteemed platform of OGSB, and I would like to thank our dear President, Professor Ferdowsi Begum, for giving me this opportunity. I'll be talking on role of tranexamic acid in management of postpartum hemorrhage. We all know that postpartum hemorrhage, why it occurs, what are the strategies to do it, and now to manage it, and now is the time to go for action. So tranexamic acid is one of the drugs which has been there's some problem with my slide. I cannot move the slides.
Farhana, what you can do, you can stop the screen sharing and then come back again, do share again. That's one way out sometimes.
They are mentioning Dr. Samrul is also already sharing the screen. So can you put off the screen share, Samrul?
So you have to stop sharing.
Shamrul is, yes, I'm doing it again, sorry. I'm going to the first slide. Yes. Can you see it now?
Yes, it can be seen.
Okay. So we are talking about postpartum hemorrhage, and globally nearly 1/3 or 1/4 of all maternal deaths are associated with postpartum hemorrhage, and it's the main cause of maternal mortality. So there are some problems with the visual estimation of blood loss, and there have been several studies which looked at estimation of blood loss, and it has been found that estimated by health workers, nearly 2/3 is missed. So these are the different methods by which blood loss has been estimated in the past. And the majority of PPH-associated death could be avoided by prophylactic uterotonics during the third stage of labor, timely appropriate management of postpartum hemorrhage. Now coming to tranexamic acid, this is a very simple drug. It has been used for a long time, but we need to revisit the use of tranexamic acid and how we can make it in our use. So most deaths from PPH could be avoided by active management of third stage of labor and prompt and effective application of the first response bundle, that is use of uterotonics, uterine massage, tranexamic acid. So this is the first response bundle where we can see that by side with the uterine massage, IV fluid, uterotonics, tranexamic acid is given, and in the first place with other supportive measures. So what is tranexamic acid? This is a medication used to treat or prevent excessive blood loss from major trauma. It may be other surgery as well, tooth removal, etc. It's a synthetic derivative of amino acid lysine and very high affinity for lysine binding site of plasminogen. It blocks, how does it act? It blocks the lysine receptor site of plasminogen and prevents binding of activated plasminogen to the fibrin surface. There is decreased conversion of plasminogen to plasmin and prevents the fibrin degradation, thus exerting its antifibrinolytic effect. It's not a uterotomy, but instead it slows the breakdown of blood clot that forms to stop postpartum hemorrhage. So this is the mechanism how tranexamic acts by inhibiting the fibrinolysis mechanism. So coming to the dose, and this is a talking point here as well, because we know about the IV route only, but the IM oral are also coming up as promising routes. So it is administered at a fixed dose of 1 gram in 10 ml at the rate of 1 ml per minute, with a second dose of 1 gram IV if bleeding continues after 30 minutes. And it should be administered by an IV route only, but their research is going on in upcoming of the other routes. I'll talk about them later in my presentation. It should be considered to be a part of the standard comprehensive PPH treatment package, and including medical, non-surgical, surgical intervention, or adapted local PPH treatment protocols. And it should be recognized as a life-saving intervention and be made readily available for PPH in settings where emergency care is being provided. So WHO has come up with a recommendation. According to recommendation, recommends that early use of intravenous tranexamic acid should be given within 3 hours of birth, in addition to standard care. And for women with clinically diagnosed PPH, tranexamic acid should be considered as part of the standard PPH treatment package and be administered as soon as possible after onset of bleeding within 3 hours. And treatment should not be initiated if 3 hours have passed. And it should be used in all cases of PPH, whether it is due to trauma or other causes. And WHO has further gone on to say that it should be administered in 1 gram in 10 ml. I've already mentioned this, and only IV route, but WHO has said that research is needed. And this is the WHO protocol in recommendation 2017. So they have also mentioned that it should be avoided in contraindicated in antifibrinolytic therapy in cases of the thromboembolic disorders of pregnancy. And in WHO, this protocol, they've compared with that of 2012, where there was another recommendation. And according to this, they have mentioned that in the 2017, the new thing is about the timing about the dosing and also how it should be given. So coming to the woman trial, the woman trial is known as World Maternal Antifibrinolytic Woman that study, which compares tranexamic acid with placebo. So they have seen the early effect of early tranexamic acid administration on mortality, hysterectomy, and other morbidities in women with postpartum hemorrhage. And this is an international randomized double-blind placebo-controlled trial. Here, women with PPH following vaginal delivery or cesarean section have been studied. Intervention is tranexamic acid given 1 gram plus standard care, and in the other arm there was there was saline and standard care. An outcome was to see the death of these women during this time, and it was found that maternal death following PPH were due to a number of reasons equal in placebo and tranexamic acid, but death due to bleeding was significantly reduced in the tranexamic arm. Also, it was found that death was reduced, but tranexamic acid, it was found that should be given less than 3 hours for maximum benefit. And this slide shows that how does it act. Survival benefit decreased by 10% for every 15 minutes delay until after which there was no benefit. So you can see here that after 30 minutes, there is no effect of the drug. And these are the results of the woman trial, which says that most deaths occur within the first 2 to 3 hours. It has been observed that most deaths occur within 1 to 3 hours. And we know that the death from postpartum hemorrhage is the earliest if not treated within 2 hours. So it reduces death due to bleeding within 3 hours and 31% reduction of death due to PPH, and reduces laparotomy for bleeding by over 35%. So this is the tranexamic acid, and we have talked about this. So now we are exploring about what is its role in prevention of blood loss. So these are the 2 studies, the TRAP1 and TRAP2 study, which are coming up. And in the TRAP1 study, they have looked in the tranexamic acid for prevention of blood loss after vaginal delivery. So they have given oxytocin in both the arms, and in one arm, tranexamic acid was given. And the conclusion was that among women with vaginal delivery who received prophylactic oxytocin, the use of tranexamic acid did not result in a rate of PPH of at least 500 ml that was significantly lower than the rate with placebo. Now coming to the TRAP2 trial, tranexamic acid for prevention of postpartum hemorrhage after cesarean section, they have given the tranexamic acid for prophylaxis, and it was found that the conclusion was among women cesarean receiving prophylactic eutotonics, tranexamic acid treatment resulted in a significant lower rate than placebo of calculated blood loss more than 1000 ml or transfusion by day 2, but did not reduce hemorrhage related to secondary clinical. That is, the other secondary clinical, it did not do anything. Now, dear audience, as I was talking about the routes of administration, what does the evidence say? So it has been found that we know that IV route, there are some limitations. That is, in the community, we cannot have it widespread use. So IM injection and oral solution would be easier and faster to administer and should require the less training than the IV route. So this is one study where they looked into the different routes of administration, and the conclusion was that clinically effective plasma concentration of tranexamic acid in postpartum women may be achieved within 1 hour of oral administration. Given the promising pharmacokinetic properties, we recommend additional studies with larger sample size to investigate the use of oral tranexamic acid for the treatment of prophylaxis. And this study is the TRACES study, where they have seen the use of IVIM. It works within 3.5 minutes, that is IVIM both, and oral takes 66 minutes. And this is the editors, they have mentioned that tranexamic acid reduces bleeding, but in low and middle income countries, administration is often not possible for several hours and bleeding continues by IV. So the pharmacokinetics after IM and oral administration were best explained by a 2-component open method. So the median time for each of these was 3.5 minutes for IM and 66 minutes for IV, oral. Now coming to so we can use this IVIM route, IM and oral route for the field, for the community. FIGO and ICM in the joint statement, they have endorsed the use of tranexamic acid, and they have recommended that tranexamic acid should be used in the same way like WHO recommendation. Now, before ending my presentation, I have 2 or 3 slides. The first talks about the challenges in implementing the use of tranexamic acid. So there are some challenges like should it be given? It should be given within 3 hours. That is a challenge. After 3 hours, it doesn't work because it doesn't work in the clot lysis mechanism. And everybody should have a broad knowledge of the tranexamic acid. It needs the worldwide recognition about its beneficial effect, and the different routes yet need to be explored, and more widespread use is needed. There are some opportunities. I think we have to think more about it, and it is easily available, low cost, and also easy to administer, but the restriction with the administer is there. But we need to use it large scale for the management and treatment of prevention and management of postpartum hemorrhage. So, dear audience, before finishing, I would like to say that tranexamic acid is a promising drug used with safety in management of atonic PPH. Its use for prevention of PPH is being studied, and different routes are also being explored. So with this note, I come to the end of my presentation. Again, thanking everybody. Thank you very much.
Thank you, madam. Thank you for the excellent presentation. So now I am requesting one of our chairperson, Professor Rohana Hatutua, for some comment on this presentation. Sir, please.
Thank you very much. Good day to everybody. Firstly, I would like to thank OGSB, the President Ferdosi, and the Secretary General Professor Gulsha and Professor Sinat for accommodating Suffolk in this wonderful conference and giving us a session. So thank you for that. And I'm very happy to see so many members of the OGSB, I mean, who are close friends of ours. Unfortunately, we are not able to be there in person, but virtually even, it is very nice to see everybody. So good day to everybody. And then I would like to tell about this session, the Suffolk session. It's on the PPH bundle, and we are very happy that Professor Burke, Dr. Poonam, and Brinda is also in this program because they are working with our South Asian countries, Bangladesh, India, and so on, in this PPH bundle projects. So we are very happy that they are in this Suffolk session. So getting on to this presentation, it was an excellent presentation by Farhana as usual, and she gave a very clear message and a very important message because of the value of tranexamic acid in the prevention and the management of postpartum hemorrhage, and that it should be given within 3 hours, and it should be given intravenously at the moment. But as he said, the oral has been tried, and there has been promising results from that, and also the intramuscularly, so which will be quite useful, as he mentioned, in the workers in the field who are unable to give it intravenously. So, but it is a very useful one, and we have not been using tranexamic acid so much, but I suppose in the future it will be used and it will be given the proper place so that we are able to manage postpartum hemorrhage at the initial stages without being wanting to go into the other procedures. So it was a very enlightening lecture, and I thank you for the clear messages given to everybody. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you so much. So our next keynote speaker is Ms. Brenda Otinio from Kenya. So her presentation is on PPH bundle, Kenya perspective. So it is the time for Ms. Brenda. So please start the session.
Good morning, everyone. Let me just pull up my presentation. Can you see my presentation?
Not yet, Brenda.
Just a minute.
Yeah, now we can see it.
Thank you very much for the opportunity to participate in the conference and of course to share our experience of the PPH bundle in Kenya. So I will be sharing briefly on the experience that we've had and outlining mostly our successes, challenges, and probably what we believe would help us scale the bundle project beyond even the grant period. So I wanted us to go through this project life course because we believe this is one of the implementation process that really helped in terms of uptake of the bundle project in Kenya. And I believe that the methodology that we use to introduce the project in Kenya is what has enabled us achieve some of the successes and the achievements that I will be outlining later. So the bundle project in Kenya was introduced in February 2020. Remember, it was at the peak of the pandemic, but then we got a very positive commitment and of course positive nod towards the project because on the first stages, we made sure to introduce the project through the societies or the professional bodies, that is COGS, whereby we had the inception meeting. We introduced on what the bundle was all about and what we wanted to implement. And I think looking at the pandemic and of course the situation in the country, being that Kenya is one of the countries with the highest maternal mortalities, they accepted the project and of course the concept of what we were talking about because they believed with all the challenges that we had, if something was not done, we would even have worse case of maternal deaths. So having had the inception meeting, we also visited the Ministry of Health in Kenya, that is the national government, also introducing what the bundle project was all about. And I believe we have seen a summary from what Dr. Thomas Bax has introduced. And they were also committed and we managed to get a buy-in from them to implement the project in the country. And with them together, we were able to identify one of the counties which had one of the worst maternal mortalities. Actually, they are put or classified within the 10 counties with the worst maternal mortalities in Kenya. So once we had the selection of the county, we went to the county teams, the leadership, and also had an inception meeting, introducing the project, introducing what the project was all about, and working together with them in terms of co-design and co-creation. Out of those meetings, we got a teaming agreement, which clearly outlined the roles and investments that needed to be put in to see the success of the project. Out of that, of course, we continued with several other engagements. I will just read through, whereby we had now the health teams or the health managers also being sensitized on what needed to be done, and of course, having them also give a commitment on what they would contribute towards seeing the success of the project. Together again, with all the team members, we had the mapping of facilities. We conducted facility assessments to see how ready our facilities were in terms of implementing the bundle project. We had a selection of the providers, that is the healthcare workers who would be trained, and of course, who would also be given the opportunity to be the mentors in terms of training other colleagues on what the PPH bundle is all about. In terms of training, we also had a layered kind of training whereby we had the county teams being trained on the bundle as the mentors. Then, of course, the mentors training the mid-level cadre as part of the trainers. before they scale the training to the other facilities. This really worked well for us because we saw that even at the point of the pandemic, instead of us as KMET going down to the ground to train, we could see the in-county teams go on with the trainings and of course support each other to implement even the bundle project. Then of course we had the commodities and supplies. Within the bundle project, KMET was providing some of the commodities. We had the uterine balloon tamponade and then a pneumatic anti-shock garment, that is NASG, to ensure that the facilities are well equipped. And of course, we continued on to provide technical assistance in support, supervision, mentorship, and of course, documentation of case studies. And at the foundation of it all, we continued with advocacy at all levels, that is national, county level, even with partners, to ensure that we had the correct investments for the bundle project. So some of the lessons that we learned throughout the process of implementation: one, we realized that the stakeholder engagement was very key because it enabled the leaders themselves to make a commitment towards implementing the bundle project and of course towards reduction of the maternal deaths in Kenya. And as you can see from the photos, this is the president from our professional society, that is Kenya Obstetrical and Gynecological Society. And we also had leaders from the Midwives Association of Kenya coming in and joining hand and taking up the whole project. And of course, talking to their peers and their colleagues towards having investments made towards the bundle project. And this, of course, made it easier for us even to get the supplies that we needed, get commodities, get even leverage on resources in terms of trainings, and of course, other investments that were necessary to ensure that the providers are supported fully to give optimum care to the women. Also, we had involvement of the local implementing partners. Migori County is one of the counties whereby we had several non-state actors implementing in the MNH space. So we had several partners doing something towards PPH management. So we had like KMET with the NASG and the UBT. We had another organization probably doing TXA. We have another organization doing something else. So as part of the bundling process, we also decided to bundle the implementers so that we are not working in silos, but we are all working together towards a common goal, which is to provide optimum care for the women. So we looked at the pre-existing relationships within the counties and of course with the other partners, and we created linkages. This was very key for us because we were able to leverage on resources and even expand beyond the scope of the project, because in as much as we were doing a pilot, we enabled to now scale even the training, scale the mentorships throughout the entire county to cover about 168 health facilities within the county with the limited resources that we had. Of course, also, we looked at our mentorship model, which we found as being very effective. As I had earlier alluded to, we started by training the top leaders as the mentors, because this was key for them to understand what was being implemented, and of course, for sustainability, to ensure that continually they will be the ones now scaling the trainings even to the lowest level of facilities. So once we had the mentors again trained trainers, and after the trainers, they also trained facility champions. So that kind of layered mentorship model also saw it being effective, especially in the period where we were having the pandemic, where there were less movements and we are having a lot of curfews in the counties. So it's helped us to ensure that the providers were well mentored, they were well coached. Even if they had new recruitments, they could easily find mentors at the ground who would actually give them the mentorship and of course train them on the bundle and what we were talking about. So this whole layered mentorship model strengthened the sense of accountability among the providers and among the leaders themselves, because they could train and they could monitor what the trainees or what their healthcare workers were doing. In terms of technical backstopping was also very important for us, and it happened at different levels. We had the national level, where we could have the national leadership together with the professional bodies, the society, and of course the organizations implementing the bundle, checking in on each other, and of course discussing progress, challenges, and maybe plans for implementation. And also it happened at the lower level, the county level, where we would have the counties, their mentors, and the healthcare providers also having their own meetings and just trying to troubleshoot on any issues that they are coming up. So the platforms were very important for us because we could easily pick up some of the challenges, even with the TXA, and I'm glad we have had that presentation. There are some of questions that were coming up because also at the time of implementation, TXA was a new innovation within our system. So most of the healthcare providers were not quite sure when to use it, how to use it, and the dosage. So having this technical backstopping was very important because whatever challenges came up or whatever new lessons they were learning, they could put it across and people would discuss on it and will provide a way forward on what needed to happen. So this again built the confidence amongst the team because they knew that together, we are in this together. So we are moving together as a team. Then of course we had the improved PPH management. What initially happened in Kenya, it was not systematic and PPH management was not that organized. Everybody worked in silos and of course the different interventions that were existed in the ground were also implemented in parallel lanes. So causing a lot of confusion and a bit of delays at the facility level. But we are glad that with the PPH bundle, what we are seeing currently, we are having more systemic and organized clinical response. And this is key because we had the introduction of those obstetric rapid response teams, which better organize now emergency care for our mothers, and of course the bundling of interventions. Currently, the providers know they do not need to wait or until the woman becomes worse, but then they know that they have to implement all the interventions as long as it is indicated for the client. So there's limited delay. Then of course we are seeing improved teamwork and communication amongst the teams. Initially we had issues with cross-cadre communications because sometimes you find it caused a lot of delay because you find the nurses probably would not initiate care until the senior doctors would give an okay for that. But now with an improved teamwork, we see them working together in tandem. The doctors working together with the nurses, consulting with the nurses, and of course, in any case, the doctor is not there, the nurse can initiate treatment even as they consult with the doctor as they come, which was initially not there, but now we are seeing more improved teamwork and communication, and of course, increased focus on preparedness. Currently, we are seeing the facilities having all the commodities and supplies that are needed for PPH management. And like was said, we currently have the facilities organizing their emergency rooms or emergency areas using the PPH kits. Some of them had the plastic boxes, which Dr. Thomas Bax talked about, but now we are seeing even new innovations in the PPH kit management, whereby we are having fabric bags where they can have all the bundle commodities and supplies, and they can use it at facility level and even in the ambulance when they're having their referrals. Other achievements so far with all the implementations that we are seeing, again, we are seeing adherence to clinical guidelines on PPH management. Initially, most of the providers would outline the guidelines and what is required to be done. But then out of the studies and out of the lessons we were getting from the field, there was little or limited adherence to clinical guidelines. But now with the PPH bundle, we are actually seeing the healthcare workers clinically adhering to what needs to be done and having the women receive, especially the first response bundle without delay. We're also seeing improved communication and teamwork, as I had already said. Introduction of the reverse referrals. Initially, the common practice was any client that needed specialized care would wait for an ambulance to be referred to the higher level of facilities for care. But then again, the referral systems in our counties or in our country is a bit broken because we're seeing challenges with the ambulances, either the lack of fuels or most of the facilities do not have the ambulances. So this has been a major cause of delay for care for our mothers. But now we are seeing innovations in the area because out of the bundle implementation, we are seeing the facilities having what is called reverse referral or what they call expertise movement. This is whereby instead of having the patient put in an ambulance and referred to an upper level facility, we are seeing the specialized care or the specialist is the one who is moving and going to the client at point of care. So it is more of the specialist care being referred than having the patient and the client delay as they wait for an ambulance for referral. We're also seeing stronger public-private partnerships because initially, again, public facilities and private facilities worked in parallel, but now we are seeing them managing the women as one. So even when it comes to ambulances if most of our public facilities do not have ambulances, they are owned by the private facilities. But now we are seeing them co-sharing and using the ambulances without added cost. We are seeing in terms of specialized care, we are seeing even the public facilities referring clients to the theaters at the private facilities without any additional cost. We are seeing them using the specialists from the private facilities without added cost, which is working well for our mothers. Also, again, we are seeing security in terms of access and availability of essential commodities. We are now seeing the leadership of the counties budgeting and, of course, investing more in having the commodities that are necessary. Key and point, we see them buying the TXS, we see them buying the UBTs, we see them buying the NASG to ensure that our mothers have all the commodities that they need for quality care. Some of the reports or the early on results that we are seeing, the county again reported, you can see, from 2019, the facility maternal mortality ratios was at around 106, but now they're talking of less than 32. So we can say that at least some of the interventions that they're implementing within the bundle project is working. Though we are waiting for the national survey, which is called the Kenya Demographic Health Survey, which will give us a better picture on what is happening, because these are facility-based data, but we can see preliminary data indicating that there's a reduction in maternal mortalities. We are also seeing the PPH fatality rates dropping. Initially, they were at 8.3 in 2020, but now we are seeing it at 1.5, and we hope that they sustain the good gains. In terms of quality improvement processes, when we started, this is just a dashboard of how it looked like in some of the key components we are checking on when it comes to the bundle project. So you can see most of the facilities were in red. Red means those are things that did not exist in the facilities. They are yet to have been started. And we can see the little bit of yellows, what they were implementing. So you can see some of the facilities, they are mostly in red. But then after our implementation, we can see the dashboard becoming a little bit of greens and now yellows. Key, I can pick out some of the facilities. Let me say the Royal. Let me see these. The second row, we can see most of the elements, they were scoring red. But now when you come here, they have most of the greens and the yellows. So you can see even the whole site orientation in terms of emergency response and equipment they're implementing something. And yes. So all this has been without a challenge, has been with some challenges. So we can see some of the challenges that we are facing. We're still having the stock issues. Some of the commodities that are also essential for PPH management, key like misoprostol, TXA, and sometimes oxytocin, we are still facing some stockouts. And of course, especially with oxytocin, we are still having the cold chain.
Sorry to disturb, please make it short. So because we are
yes. Thank you. Then of course, we are seeing with the referrals, ambulances, not always available when needed. Then of course, we are still having our industrial actions. Those are the strikes, the healthcare workers striking because of one or two things. Some of the challenges are still the documentation. Again, we see documentation has not been good. So those are areas that we are trying to strengthen to ensure that we are getting all the data and all the women are documented. And then, of course, one of the things that we are getting from the PPH bundle again, there's the introduction of the debrief session, which all facilities are saying is important and is working well, especially in terms of improving the quality of care. But then we are seeing they're still having challenges in terms of implementation. And this has been because of staff shortage and, of course, the work overloads that they're having in the facility. So in conclusion, I think with us, the experience with the PPH bundle is good, and we feel that it is something that can work towards improving or reducing maternal deaths. But then we still need investments when it comes to enhancing local leadership, scaling mentorship, and of course, enhancing quality improvement frameworks. So currently, the government has taken up on the quality improvement projects towards ensuring that the bundle project works. And with that, I'd like to thank you all for the opportunity given to us to share our lessons. And of course, I believe we will do more as we continue to learn and share. Thank you.
Thank you. Thank you, Brenda, for your excellent presentation. Professor Rahima Begum. Madam, please comment some thing on this presentation.
শোনা যায়? শোনা যাচ্ছে?
Yes, madam, you're clear.
Thank you very much. Thank you, Dr. Brenda and Attorney for your excellent presentation. And thank you, the organizer, to give me the opportunity to say something in this platform. So this all PPH what is saying from first to last is very exciting lecture. And of course, if we'll go through these all lectures and this last project course, which is shown by the Branda, it is excellent presentation. And if we follow this presentation or we can apply this to our country, it will definitely reduce our PPH mortality rate. Though we are giving training and following this PPH bundle in different angles of our country. And PPH bundles is already in our country, is in progress. So in later, we will hope that the PPH will be reduced and our maternity rate will be reduced by listening and by applying these all the nice guideline from all this Brenda, then first Dr. Farhana one, and also the first presenter. So we want to do all in collaboration so that PPH, the death from PPH in this Indo-Asian country will be decreased and our leadership will give the chance to survive these ladies. And PPH is really difficult in our country at a time, but nowadays PPH is coming down because of this all bundle and because of this different medicine and proper intervention in proper time. And using this also grassroots level to prevent the PPH, to identify the people who are actually in risk and who are started the PPH, how to manage and how to refer the patient. We give the training to this mid-level and grassroots level people also. So thank you again, Professor Brenda, and to all to have this excellent presentation. Thank you.
To the reporters, is she out of connection?
Thank you.
Thank you. Yes, Deva.
Thank you. Thank you, madam. Thank you for your presentation. Thank you, madam. Thank you for your presentation. So in this session, our speaker is Poonam Verma Sivkumar, professor and the head of NGIMS Sivgraph, Wardha, Maharashtra, India. She is a core member of PPH working group FIGO. Madam, please, your presentation is on NAGSG in PPH management, achieving on the impossible target, 0 death due to PPH. Madam.
Thank you so much. Am I audible?
Yes, Poonam.
Yes, ma'am. I'll just share my screen in a minute. Is it seen?
Yeah, clearly
Yes,
visible.
madam.
Okay.
So a very good morning to all of you. First of all, I would like to thank the SEFOC President, sir, to give me this opportunity and the whole team of Obstetrics and Gynecological Society of Bangladesh. So what today I'm going to talk to you is non-pneumatic anti-shock garment in obstetric hemorrhage. I bring greetings for you all from Mahatma Gandhi Institute of Medical Sciences, the only medical college which was started in rural area by Mahatma Gandhi himself. And we still abide with his principles. We are known for our ethical researches and also known for our community service. Well, in my presentation today, I'm just going to give you a small introduction about what NASG is, what are the components, what is its mechanism of action, where do you use it and where you should not use it, what are the methods of application, removal, cleaning, and storage, and what has been our experience worldwide on NASG. We all know that non-pneumatic anti-shock garment is a very unique, very low technology, life-saving device, which is made up of neoprene and Velcro, and it is very effectively being used nowadays for preventing the deaths because of obstetric hemorrhage, and I'll tell you how. It can be applied by anyone.
Your slides are not moving.
They're not moving?
No, and can you make it full screen as well?
Ma'am, I did try to make it full screen. The moment I make
it's okay.
it full,
It's okay.
Yeah, now you will be seeing it, but if I make it a full screen, it doesn't move. So I'll just go with this only. So when we are talking about non-pneumatic anti-shock garment, as I told you, it's a very low technology device. It is made up of neoprene and Velcro. It can be applied by anybody with a very little medical training. And it has a very unique role where it prevents shock and the women comes to you alive. So it stabilizes the pulse and blood pressure until the women reaches to a right place. And this is why NASG has a very great role when it comes in terms of referring the patient during transport. Now, if you look into this non-pneumatic anti-shock garment, you will see that it has got several segments on both sides. So it has 1, 2, 3, 4, 5, and 6 segments. And it starts right from ankle, goes up to the navel, and I'll tell you how we will apply it. The concept of this started in United States of America with NASA, where, you know, the astronauts would go up and during acceleration, the blood would be squeezed from all the peripheral part to the brain, so as they are quite conscious and they know what is happening. Obstetric hemorrhage, we all know that this is a major reason for deaths in all over the countries. And NASG has been designed as a first aid device to treat hypovolumic shock due to obstetric hemorrhage. And I'm not going to go in details because we all know that during antepartum period, during postpartum period, and even in early pregnancy, the hemorrhage which happens because of this reason is inevitable, and we need to treat shock before we really go into the management of the cause. So what are the indications of postpartum hemorrhage, of NASG application? So the postpartum hemorrhage is one of the very important reason for applying NASG. And if you see, we are talking so much about PPH bundle because now this PPH bundle, which we worked here in 11 medical colleges, it has gone to UP, it is going to several states in India, going to Bangladesh also, going to Kenya also, and several parts of the world. And you see one of the major components of refractory PPH management is anti-shock garment. So when do you apply NASG? Whenever you see that with hemorrhage, a woman has come in shock, she has increased pulse, decreased blood pressure, her respiration is rapid, she is looking pale, sweating, and all the signs of shocks are there, which can be detected. And also you can see that there is heavy external bleeding. There is one question that when do you not put the NASG? So this is when there is a viable fetus. So when it comes in terms of pregnancy, there's a huge big problem. And whenever there is bleeding which is above the diaphragm, then you cannot put it. Any thoracic wounds, congestive cardiac failure, mitral stenosis, and trauma victim, one has to think before putting it over the women. So if we look into right indications, we say all variety of obstetric hemorrhage. Before delivery, these are the ones. And after delivery, we know it is PPH for any reason. Now, as I am telling you, on one side, I say that it is a contraindication when the baby is inside. On other side, I say that it can be put for APH. So there is a very peculiar way of putting it. And there, the whole NASG cannot be used because you would not like to compress the abdomen. But till thigh, you can put the NASG. What is the mechanism of action? As I told you, that the moment we apply this particular device, it puts pressure on the lower body and abdomen and thereby pushes the blood all to the vital organs and stabilizes vital signs, resolving to some extent hypovolemic shock. Once fitted correctly, the reusable NASG forces the blood to the essential organ, which is the crux of it. And if we look into the physiological principle, you can very well say, clearly see in this particular slide that in decompensatory shock, the blood is all cooling down. And the moment you put this NASG, the whole blood is directed upwards and goes to the brain and the women reaches to you alive. Now we come on to the most important thing, and that is how do we apply NASG? So when we are applying NASG, there are 3 marks which you see on NASG. One is if it is a conscious woman who's of average height, there's this mark and this color. How to apply on conscious women who's shorter, because many of the places you will find that the height of the women is shorter, and how to apply it on the unconscious women. There are different ways. Now we come on to the step 1. In step 1, first thing is to call for help, whoever is available. It could be a health worker, family member, porter, driver, cleaner. Please call somebody. Shock is easier to manage always in a team. Then step 1 is that first everybody in the facility has to know where NASG has been stored. So there should be not even a minute taken to bring that NASG. Then you have to wear gloves while applying NASG. And if the woman is conscious, you allow her to lie down and ask her to raise the feet, bear and lift her hips, and where from the whole NASG is pushed beneath her back. In step 2 also, if she is sitting up or able to move easily, you may spread out NASG on the bed or surface, and then you can ask her to lie down on the top of it, and this is much easier. Then the top of the NASG, segment 5 and 6, have to come to the lowest rib. So 1, 2, 3 would be on the legs. And as far as 5 and 6 are concerned, so 4, 5, and 6 generally come over the abdomen, but the topmost part should be at the lowest rib, and the pressure ball, which is 6 number, that has to be put on the navel. Next, we have to look at her ankle. If the bottom of the NASG, the first one has to be at the ankle. That is the step 4, where we start closing the step, the first part of the NASG at the level of ankle. Now, when is a short woman, you have to fold this number 1 NASG part, and you have to start from 2. So the first part is folded in short way. Starting at the ankle, close the pair, 1 tightly around the ankle. So both the sides simultaneously, you are going to close number 1. To apply tightly, apply each segment by first putting the non-Velcro side with all your strength over the leg or the body. So you have to, you have to put that Velcro with a lot of strength. And to check that, there is a test which is called snap test, which I will come on to. then you have to pull Velcro side with all your strength over the leg and body and secure it on the first side by Velcro fasten. To check that segment is wrapped tightly enough, put your finger under the top layer of the closed segment and pull the fabric. It will give you a very sharp snap sound. So the moment you get that sound, you are sure that you have tied it properly. And then you go on to the pair 2, which is very tightly put on the calf, and you have to have the snap test here as well. And if possible, leave room between pair 2 and 3 segments so that your knees are free. So the third segment should be put on the thigh with ensuring that your knees are free. Why? Because in this situation of refractory PPH, you may have to put uterine balloon tamponade or do a procedure on vagina. So her knees and thighs have to be free. So the third segment is kept on the thigh with knees free. And then you have to apply it tightly, do the snap test again. If there are 2 people, one on each side, they are applying the segment, that's perfect. But even if it is one can do it simultaneously. Then after placing this, now we have to place 4, 5, and 6. So when we are placing 4, we have to also ensure that the hip joint is free. So we have to apply it in such a way that you don't push the segment on the thighs, on the hips, so that your hip joint does not move. Stay a little above that. Apply 4, and then 5 would be exactly below the lower rib, and the 6th segment would be on the navel. And they all have to be tied with lot of pressure. So as what you do is that you know that your snap test is positive and there is a good compression which is going to help you with it. So this is what is the segment 5, which is at the lower part of the upper part of the, the upper part is at the lower part of the rib. And then you are seeing that this is the way the whole thing has to be tied. 6th segment is always a ball which is on the interior side, and then again you have to put it so that it causes a bit of aortic compression. So this is what I wanted to tell you, that the 6th segment, which is a ball kind of thing, it puts pressure near the umbilicus, slightly left to it, and it also works as aortic compression. So it works 2 ways, that it also causes a bit of aortic compression. So this is operating step summary. When you are placing NASG, you have to place it under the women. 1, 2, 3 have to be tied. And third one is to be tied in such a way that you leave the knee. Then you close the 4th segment around the pelvis, but ensure that your hips are moving. Then you have to apply pressure ball and close the 6th segment. So the 5th, I think I said 6th, it is the 5th segment which goes as a pressure ball. So please correct that. It's the 5th segment which goes as a pressure ball and the 6th segment comes over it. So this is about the operating summary. So if you look into the correct application, you can see that knee and hip can be moved very easily. And this is an incorrect application which should never be done. How do you remove and when do you remove? So once the women
Madam, it is a gentle reminder to make it short, please.
Yes, please. So you have to remove it the moment you see that the blood pressure and pulse is settled. And every 15 minutes, you keep checking it. The women is at right place, you can remove. People also say that if you are doing cesarean section, you need not remove 1, 2, 3. You can remove 4, 5, 6, do the section, and then you can re-clean. It's very important that we know how do we clean it. And there is a brush initially which removes all the material which is attached. It is to be kept in the bleach solution. And then it has to be washed by the detergent. After washing it by the detergent, it is hanged indoor at a place where it dries. In a minute, I'm going to share with you what have been our experience. Sevagram has done this. We have NASG in our periphery, and 42% cases have come who have been taken directly to operation theatre, and we have saved them. There's a very big trial, boost trial, which has been done in Uttar Pradesh for this. And there is Loni institution where Dr. Bangal has used it on 106 patients with severe variety of shock and has come up with good results. So it is very, very useful, especially with UBT in PPH cases as a part of refractory PPH bundle. Friends, I'll just end my presentation by telling you that there are some challenges of cost, how to exchange this, how to store, clean, and what kind of training should be given. But this all has been sorted out. Even two places which have NASG, they can exchange, and they can, the moment she comes, the normal NASG is returned, and this NASG is kept in the facility. These are our evidences. And Sula Miller, we thank her for bringing this to us. Thank you so much for your patient hearing. And I would like to acknowledge Dr. Thomas Burke and Dr. Bangal, the whole team of MGH, for giving me this opportunity to do this particular study. Thank you so much.
Thank you, Dr. Puram, for your excellent presentation. Now, I'd like to request our chairperson, Professor Firdausi Begum Madam, to make some remark on this presentation, followed by the conclusion note.
Thank you. Thanks to the whole team who are working with this PPH bundle and currently engaged themselves with such an important endeavor. You know, the mothers are dying every day. So this is our must to work hard with concentration, so that how can we reduce PPH, death due to PPH and the consequent morbidity and mortality and so on and so forth. And I must be thanking Poonam, because whoever has gone to Mahatma Gandhi Institute of Medical Sciences, the very ethics and the very environment of that area is so much inducive and so much influensive that I request all of us to have that essence if we visit that place personally. We cannot even imagine how can people of this age retain such ethical principles. And of course, the PPH bundle, the NASG, fantastic things they're doing. And thanks, Poonam, for being so elaborate and so methodical. This is Poonam, of course, and the whole team of PPH bundle here. Dr. Rohana, under the able leadership of President of SAFOG, we are trying to move this forward in the whole SAFOG region. And we are presently having activities with Foxy and of course this SAFOG team, Bangladesh team who is doing this, and Dr. Burke and your team. We are thankful to everyone, and I must be congratulating the scientific committee and the team of this session for conducting it well, and I hope it will really help us to take this forward and save our mothers. Thank you.
Thank you, Madam. Thanks to all our chairpersons for conducting the session so successfully. Special thanks to all four speakers. The information and knowledge that they shared with us through this session will surely help us to manage our PPH cases. Thanks to our moderator, Professor Dilruba Zeba, and also our sincere thanks to the pharmaceuticals companies who technically supported us throughout the session, and also our OGSB staffs whose continuous support helped us. Thank you to the participants for patience hearing. Thank you.
Thanks to everyone, especially Dr. Rohana. Rohana, thanks. You can speak a bit.
Dr. Rohana, you can make some comment on this session.
Thank you, Firdausi, and everyone for giving this opportunity to SAFOG, but I won't take time as we are behind time in the program. So again, once I once I wish to thank all the speakers for their excellent presentations, which has given us a very clear picture on this bundle approach to control PPH. And it's a very exciting and a very encouraging project which is being carried out in several countries. And I hope that we'll be able to continue this and carry on this to the other countries so that everyone will benefit from this PPH bundle projects. Thank you very much again to everybody. Thank you.
Thank you, sir. Now I'd like to hand over the mic to the rapporteur of the next session.
Thank you. Dear participants from home and abroad, Assalamu alaikum and good morning. I am Dr. Sumaya Akhtar, Assistant Professor of Gynae and Obs Department from Popular Medical College, welcoming you all to this 30th International Scientific Conference 2022 of OGSB as the rapporteur of the session. Now, our session is AOFOG session with the theme of COVID-19 and women's health. This session will be chaired by 3 eminent professors, and we have 4 renowned speakers with us. Now I am requesting Professor Kishore Sultana to moderate the whole session.
Thank you, Dr. Sumaya. Assalamu alaikum, ladies and gentlemen. I am Professor Kishore Sultana, member of Executive Committee of OGSB, welcoming you all to this AOFOG session. Before we start, I would like to pay respect to our language martyrs. Our session is for 1 hour. The speakers are requested to complete their presentation in time. The session will be very befittingly chaired by 3 honorable chairpersons. Dear audience, let me introduce our chairperson first. Professor Kajunuri Ochiai is the president of AOFOG, chairperson, Asian Gynecologic Oncology Group. Our next chairperson, Dr. Rohana Hatutua, well-known gynecologist, is the Secretary General of AOFOG and President, South Asian Federation of Obstetrics and Gynecology, President, South Asian Federation of Menopause Society. Moreover, we have another respectable and dynamic chairperson from Bangladesh, Professor Muhammad Abdul Halim, Principal of Kumudini Women's Medical College, Bangladesh. We have very important 4 presentations by eminent speakers from around the globe. This session is further enriched by Professor Krishnandu Gupta from AOFOG, who will conduct the very interactive question and answer part of the session. Dear audience, I would like to request Professor Kajunuri Ochiai to give his opening remark of the session. Over to you, sir.
Thank you. Thank you, moderator and rapporteur. And good morning. Good afternoon, everybody. I am Kazunori Ochiai, the president of Asia Oceania Federation of Obstetrics and Gynecology, AOFOG. And I'm delighted to deliver opening remarks of AOFOG session. First of all, I am appreciate to Professor Ferdowsi Begum, President of OGSB, Professor Gulshan Ara, Secretary General of OGSB, and Professor Skujina Ara Naslim, Scientific Secretary of OGSB, to hold this AOFOG session in 30th International Scientific Conference of OGSB. OGSB is one of our members since 1976 and very supportive to AOFOG. Professor T.A. Chowdhury served as a vice president of the term of 1998 to 2000. OGSB has set AOFOG session every year, and I have enjoyed OGSB conference many times before. Today's theme of AOFOG session is COVID-19 and women's health. COVID-19 is still rampant all over the world, and new variant Omicron strain is somehow different from previous strain regarding infection ability and severeness ability. But it is really affecting women's life, women's health in many ways. AOFOG has moved promptly to prepare for COVID-19 pandemic. Since we needed updated right information on COVID-19, we opened COVID-19 corner in our website. Professor Lumbiganon was appointed to a chair of COVID-19 advisory group, which helped to coordinate this corner. Our committee chairs supported to organize many webinars. Some of them are today's speaker. I hope you will see how COVID-19 threatened women's health and how we have been tackling with it to maintain women's health in AOFOG region. Thank you very much.
Thank you very much, sir. With the permission of the chair, we shall begin the session. Before this, I request if anybody have any question, please write in chat box, which will be discussed later on. At first, I would like to invite our first presenter, Professor Pisaki Lumbiganon, President-elect AOFOG, Professor of Obstetrics and Gynecology, Faculty of Medicine, Khan Kean University, Chair, COVID-19 Advisory Group, AOFOG. Sir, please.
Chairperson, ladies and gentlemen, I would like to thank the organizing committee of the OGSB conference for the kind invitation. I don't have any conflict of interest for my presentation today. The pandemic of COVID-19, with the official name of Severe Acute Respiratory Syndrome, Coronavirus 2, or SARS-CoV-2, started in Wuhan, China, in late December 2019. The first COVID-19 case outside China was reported in Thailand on the 13th of January 2020, over 2 years ago. Very soon after that, our president of AOFOG, Professor Katsunori Ochiai, initiated, with the support from the member of the executive committee of the AOFOG, a COVID-19 advisory group, and established COVID-19 corner on AOFOG website. I was appointed to be the chairman of this advisory group, and the members include Dr. Ratanasili from Sri Lanka, Dr. Gupta, Professor Gupta from India, and Professor Baba from Japan. And this slide shows you ELFOC website, and COVID-19 corner is here. By the way, I would like to cordially invite you to attend our ELFOC Congress 2022 in Bali, Indonesia, during 23rd to 26th of May this year. It will be organized in a hybrid platform, but you are mostly welcome if COVID-19 situation allow to attend in person in Bali. This is the content of our COVID-19 corner. We include COVID-19 advisory group, ELFOC statement, guidance to public, guideline from national society, guideline from other society, international organization guideline, and webinar program. This is the most latest ELFOC statement just received from Professor Salikapan Vilailak on the 7th of this month. That is only 4 days ago. ELFOC statement on COVID-19, gynecological oncology. And the most recent one is ELFOC statement on COVID-19 in pregnancy by Dr. Latanasili and his team. Just sent me yesterday. All of these revised ELFOC statements will be circulated to members of the executive committee of ELFOC to give comment and approval before uploading to the COVID-19 corner. This is the public guidance to patients undergoing gynecological treatment who are considering vaccination against SARS-CoV-2 virus. This is the most updated international organization guideline that was uploaded in our COVID-19 corner of ELFOC website. From RCOG, we have treatment of COVID-19 in pregnant patients, just published on the 7th of December, 2021. Coronavirus COVID-19 infection in pregnancy, published on the 11th of January, 2022. Also from the World Health Organization, we upload living guidance for clinical management of COVID-19, published on the 23rd of November, 2021, and therapeutic and COVID-19, published on the 14th of January this year. We provide also the linkage so that our members can have direct access to this guideline or recommendation. We also have webinar programs, including COVID-19 and fertility care, COVID-19 in pregnancy, impact of COVID-19 on sexual and reproductive health in ELFOC region, vaccination in women, COVID-19 in gynecological cancer management. We were requested by Dr. Lohana, our Secretary General, to give some information about our COVID-19 corner in ELFOC newsletter. This is the latest one in September 2021. And we focus on two important issues. The first one was about caring for women with COVID-19 during and after pregnancy. COVID-19 vaccination for pregnant and lactating women. We also provide information about vaccine policy on pregnancy in various countries around the world. We present the 3C COVID conundrum and curveball in the fifth goal we sent Congress in October last year. And we cover what are the issues, what are we doing, what are we working with. We also give a presentation at the 26th Seoul International Symposium. And our topic was recent Cochrane reviews for treatment of COVID-19 patients. I would like to sincerely thank Professor Sunori OGI for initiation ELFOC activities on COVID-19, organizing the advisory committee and establishing the COVID-19 corner. ELFOC executive committee members for continual support and give comment to our statement. Dr. Lohana Hatotuwa for his continuous encouragement and support. And lastly, Ms. Flora Philip for her continuous secretary support. Thank you very much for your kind attention.
Thank you, sir, for your concise and informative presentation. And also thanks for your invitation. Now, we have a very important presentation on COVID-19 vaccination in pregnancy, the future direction by Professor UDP Ratnashiri, immediate past president of SLCOG, chairperson, MFM committee, AOFOG. Over to you, sir.
Thank you very much, organizing committee of OGSB and the AOFOG for giving me this opportunity. So my topic is COVID-19 vaccination in pregnancy and future directions. So pregnant women and women who are breastfeeding are already routinely and safely offered vaccines in pregnancy. These vaccines, like COVID-19 vaccines, are non-live vaccines, and they are considered safe in pregnancy and breastfeeding. So when you take the risk of severe COVID infection among pregnant women, they are more likely to have severe COVID infections if they are overweight or obese, and the Black and Asian minority ethnic community, and when they have other comorbidities like diabetes, hypertension, and when they are older, about 35 years. So I think now we all know about the COVID-19 vaccine policies showing 222 countries and territories, and they are divided, recommended for some and all in 97 and 51 permitted. When you see our region, AOFOG region, including Bangladesh, Sri Lanka, India, and other countries, most of them are belonging to green and the blue regions. So they are permitted to have COVID-19 vaccines, and some regions in the world are still not recommended to have COVID-19 vaccination. So this is the current situation in the globe vaccination. So there is no non-risk associated with giving inactivated, recombinant, viral or bacterial vaccines or toxoid during pregnancy or while breastfeeding. Since inactivated vaccines cannot replicate, they cannot cause infection in either mother or the fetus. Although the AstraZeneca COVID-19 vaccine contains a live adenovirus vector, this virus is not able to replicate. So it will not cause infection in the mother or the fetus. Although the clinical trials on the use of COVID-19 vaccines during pregnancy are not advanced, the available data do not indicate any harm to pregnancy. That is the green light. And the Joint Commission on Vaccination Pregnancy has therefore advised women who are pregnant should be offered vaccination at the same time as non-pregnant women, based on their age and clinical risk group. Now, once you have the first vaccine, second COVID-19 vaccine to be given at the recommended interval, regardless of the gestation of pregnancy. And people who are pregnant may receive COVID-19 vaccine booster shot 3 months after the second dose. This is the recommendation of the WHO for vaccination in pregnancy. Now, we have a few vaccines. The commonly used vaccines for pregnant women are the Pfizer and Moderna vaccines, and because more extensive experience of using pregnancy. Now, pregnant women who commenced vaccination with AstraZeneca, however, are advised to complete with the same vaccine. Before vaccinations, the clinician should discuss the risks and benefits of vaccination to the women, who should be told about the limited evidence and safety of vaccine in pregnancy. Now, the Sinopharm, the Chinese vaccine, is also recommended in pregnancy and lactation by the WHO. So, but we need further research on the following: the clinical unknowns about COVID-19 vaccination efficacy on transmission, duration and protection against severe disease and asymptomatic infection, and the duration of immunity following infection or vaccination, or both, and the long-term protection after different vaccination intervals, protection after single dose vaccination and regimen. So these are still needing research regarding the vaccination. Now, routine questioning about last menstrual period or pregnancy testing is not necessary before COVID-19 vaccine. Women who are planning pregnancy in the immediate postpartum period or immediate postpartum period can be vaccinated. If a woman finds that she's pregnant after she has taken a course of vaccine, she may complete the vaccination during pregnancy using the same vaccine products unless contraindicated. Alternatively, vaccination should be offered as soon as possible after the pregnancy. Now, what are the contraindications and precautions? There are only few individuals who cannot receive these Moderna and AstraZeneca COVID vaccines. Where there is doubt rather than withhold in vaccination, get appropriate advice from the relevant specialist or from local immunization or health protection team. The vaccines should not be given to those who have had previous systemic allergic reactions, including immediate onset of anaphylaxis to a previous dose of same COVID-19 vaccine or any component of the COVID-19 vaccine. So minor illnesses without fever or systemic upset are not valid reasons to postpone vaccination. Now, the advantage with vaccination during pregnancy, these antibodies might protect the baby as well. When people receive mRNA COVID-19 vaccine during pregnancy, their bodies build antibodies against COVID-19, similar to people who are not pregnant, and these antibodies made after a pregnant person received vaccines are found in umbilical cord blood. This means COVID-19 vaccination during pregnancy might help protect babies against COVID-19. So more data are needed to determine how these antibodies similar to those produced with other vaccines may provide protection to the baby. Now, these are the common side effects. If you see the side effects with 3 compared vaccines, Moderna, Pfizer, and Janssen, the commonest one is the reaction at the site of infection, and fatigue, chills, muscle pain, joint pains are similarly seen among these, but not very much compared to fever. Fever is the least common side effect seen in these vaccinations. Now, these are another pictorial demonstration of the side effects which had been seen after the first, second, and third. I'm not going to go into details. And allergic reactions, including anaphylaxis, had been seen, but when you see the number of cases with Pfizer BioNTech vaccine, only 5 per million, and Moderna only 4.9 per million, and with Janssen vaccine, 7.6 cases per million doses administered. So these are the data available with allergic or anaphylactic reactions. And there's another condition called thrombosis with thrombocytopenia syndrome, which was seen 8.9 out of every million doses of COVID-19 Janssen vaccine. And this is seen mostly among females aged 18 and 24. Now, we need a post-administrative pregnancy surveillance data. As of November 29, 22, there have been over 177 pregnancies reported to CCB Safe Post-Vaccination Checker. Based on this limited self-reported information, no specific safety signals have been observed in pregnant women enrolled for this group, and how longitudinal follow-up is needed. And if you compare among these countries, about 5,294 individuals, they are likely, whether they are like to have vaccine or not like to have vaccine. So if you see the bottom, Russia, Australia, United States, many of them are not likely to get this vaccine, even if it is given protection for 90%. And when you come up to the other countries, Brazil, Peru, Philippines, Mexico, most of them are likely to get the vaccine. So there's a difference of perception of or feeling how they can be safe and how they can be protected among world population. Now, when you take the estimated number of women who need to be prevented with the infection or any other conditions among 1,000 women, to prevent one adverse outcome with COVID-19 infection, at least 11 to 56 people needed to be vaccinated, and symptomatic infection 41 to 206. When you consider the severity, ICU admissions, you need to vaccinate 1,010 to 5,051 to get the protection, and ventilation 1,371 to 6,057 among 1,000 pregnant women to prevent these kind of complication. And the bottom will show preeclampsia, small for dates and other conditions. I'm not going to go into details. So you can see how much of vaccination is needed to prevent these complications per 1,000 pregnant women. And so this vaccination has shown reduce the rare conditions like direct admissions to maternal ICU, mechanical ventilation with ECMO, or maternal deaths have reduced, and indirect reduction of the following common conditions of COVID-19 infections: iatrogenic preterm birth, cesarean delivery, stillbirth, healthcare access, increased mental distress scores, and mother-infant separation following delivery, and interruption of breastfeeding had been reduced to significant level with the vaccination. So at last, what I want to tell with other precautions, COVID-19 vaccination in pregnancy, it is the best method to reduce maternal morbidity and mortality among pregnant women due to this infection. So that is the message, take-home message, and we should promote this vaccination among pregnant women, however, with counseling, and this may reduce the number of maternal morbidity and mortality with direct or indirect COVID-19 infection. Thank you very much for giving me the opportunity. Thank you.
Thank you, sir, for your illuminating lecture, which is much relevant to the current pandemic situation. Now, I would like to request Professor Sharikapan Wilaila, Professor of Obstetrics and Gynecology, Deputy Dean for Academic Affairs and Culture, Thailand, Committee Chair, Oncology, AOFOG. She will talk on COVID-19 and oncotherapy, the current scenario. Madam, please.
Thank you very much, Professor Sultana, for your kind introduction. And good afternoon, dear colleagues. First of all, I would like to thank OGSB and AOFOG for giving me an opportunity to give a talk on the topic COVID-19 and cancer, current scenario. I have no conflict of interest. Both cancer and COVID have several dimensions. In cancer, there are prevention, screening, diagnosis, treatment, and follow-up. In COVID, there are vaccination and pretty much the same. Does cancer worsen COVID condition? And does COVID worsen cancer condition? The COVID-19 pandemic has changed the world. It created unique challenges and distress for both patients with a cancer diagnosis as well as providers who care for them. I will cover the impact of COVID-19 on cancer and impact of cancer to COVID-19 patients and conclusion. Impact of COVID-19 on cancer. Cancer patients are at risk of getting COVID, both because of their underlying disease and the immunosuppression associated with the treatment they are receiving. The recent Wuhan cases of 1,500 patients reported in JAMA Oncology show that the infection rate in cancer patients was double that general population. As you can see, 0.8 compared with 0.4%. General considerations are the management should bear benefit to the patients more than risk. Health resources must be prioritized. The management should be individualized for each patient. That means one size doesn't fit all. And communicate clearly with the patients is very important. Both patients and health provider exposure to COVID-19 must be minimized. All reasoning behind each decision is to be recorded Telemedicine is therefore considered. Decision about getting screened depend on many factors. Elective medical procedures, including cancer screening, were largely put on hold to prioritize urgent needs and reduce risk of the spread of COVID-19 in healthcare settings. These contribute to a large drop in cancer screening. Therefore, balancing risk and benefits of screening along with making sure both patients and healthcare are safe. As you can see here, the impact of COVID-19 on colorectal screening for Asia-Pacific countries, including Australia, Korea, and Japan, etc. The number of screening in 2020 in green bars, compared with gray bars, the screening in 2019, which dropped remarkably. Indication for surgery is classified as elective, non-urgent, semi-urgent, and urgent emergent. Most gynecologic cancer cases are semi-urgent surgeries, second only to trauma cases and surgical emergencies. Accurate triage is critical to preserve resources and protect staff and patients. Tests for COVID-19 prior to surgery is recommended. British Gynecological Cancer Society recommends emergency surgery to be performed within 24 hours, urgent surgery within 72 hours, elective early surgery within 4 weeks, and elective delayed within 10 to 12 weeks. In case of chemotherapy, a limit on frequency of infusions is recommended. Do avoid weekly infusions. Consider oral therapy instead of infusion-based treatment when appropriate. Consider less frequent dosing intervals regimen and single agent therapy or holding cancer-directed therapy for patients more than 65 years old. For radiotherapy, patients with rapidly proliferating tumors are in the highest priority group. Do consider hypofractionation, that is, increase dose per day and reduce the number of fractions to reduce the number of times necessary for patients to visit the hospital for treatments. Alternative treatment, for example, patients with grade 1 endometrial cancer can be considered for conservative treatment with non-surgical options, including systemic hormonal therapy or medicated intrauterine device instead of surgery, of course. And in patients with advanced ovarian cancer, consider neoadjuvant chemotherapy until crisis is resolved, and then consider surgery at a later time. Those who have recovered from COVID-19, the ASCO considered it is reasonable to resume anti-cancer treatment. Once transmission-based precautions can be considered based on CDC or Center for Disease Control guideline. For example, for those with laboratory confirmed COVID-19, they should be at least 10 days from the date of COVID diagnosis or first appearance of symptoms, or 2 consecutive negative SARS-CoV-2 test results collected at least 24 hours apart. Patients who are in disease remission should be deferred from routine follow-up, and those with stable active disease should have less frequent hospital visits. Follow-up by phone or video should be considered. They should be given a contact number so that they can advance their appointment if they developed any symptoms. Multidisciplinary meeting should be continued on regularly basis, especially treatment may need to be deviated from the usual practice and prioritize them. Instead of face-to-face meeting, online meeting should be considered using Zoom, WebEx, or equivalent. Impact of cancer to COVID-19 patients. Cancer patients infected with COVID has greater risk of severe infection and death than the general population. In a study by Yu et al. In JAMA Oncology 2020, as you can see, there were 39% of COVID patients with cancer admitted to ICU, ventilated, or death, compared with only 8% of COVID patients without cancer, with P 0.0003, which is very low. As you can see from the bar graph here, severe events are rising in patient without cancer, cancer survivor, and patient with cancer, respectively, as you can see. And from this graph, the probability of developing severe event for patient with cancer is much higher compared with patient without cancer. Cancer patients is vulnerable. Therefore, COVID prevention is most crucial. To stay home or in a safe place, education about signs and symptoms of COVID-19, as well as the general hygienic measures and vaccination against COVID are all important. In conclusion, there's a clash between COVID and cancer, of course. COVID and cancer each has adverse effects on each other. COVID-19 pandemic poses several challenges for oncology services, as we can see. Our ultimate goal is highest quality of medical services possible in this pandemic. The only way to get through the war of COVID and cancer is for us to share knowledge, best practice, and to collaborate more going forward, helping each other through this difficult time. Thank you for your kind attention.
Thank you, Madam, for your knowledgeable speech, which helps us to contact with patients more smoothly. Now, our next speaker is Professor Gulshan Ara Madam, Secretary General of OGSB, Editor Journal of ESB, Office Secretary PCOB. Madam, please. Madam, please share your slide.
Thank you, Professor Kishwar Sultana. Respected chairpersons of these sessions, moderator, rapporteur, and learned audience, very good afternoon. I would like to express my sincere thanks to AOFOG to give me the opportunity to say something about situation of COVID-19 in Bangladesh and overview. We are mourned. Hats off to the frontliners. May Almighty rest them in peace. We have lost more than 200 doctors of Bangladesh, including our 16 beloved gynecologists in COVID-19 period due to infection. And these are the pictures of our beloved gynecologists and pictures of Bangladeshi doctors who lost their lives in COVID-19. China observes a very special type of infection in December 2019 at Wuhan, the capital of Hubei province, and the 7th largest city in China, and population more than 11 million. In early 2020, the World Health Organization identifies this infection as a new type of coronavirus. The SARS-CoV-2 is one of the 7 types of coronavirus, including that cause severe disease like MERS and SARS. COVID-19 pandemic in Bangladesh is part of the worldwide pandemic of coronavirus disease caused by SARS-CoV-2. The first 3 known cases were reported on March 8, 2020 by the country's Epidemiology Institute, IEDCR. And Bangladesh is the second most affected country in South Asia after India.
Kenapa di pilot siapa?
Lee et al. Analyzed first 425 cases from Wuhan. The median age of the cases was 59 years, 56% of the confirmed cases were male, and incubation period was 2 to 14 days, and the mean incubation period 5.2 days, but recent update about the incubation period extend up to 24 days. Elderly patients and other pre-existing condition had higher morbidity, and reports suggested the virus was infectious. Till date, origin of the virus is not controversial, is not till now. Primary host and intermediate host is not established till date. Full genome published in Jailbank and several strains likely. Transmission man-to-man, mostly droplet infection, direct contact, touching, shaking, fomites, touching contaminated object, fecal-oral transmission is older. On March 11th, the WHO declared COVID-19 as a pandemic. Timeline of the symptom is mild symptoms is about 80%, moderate 15%, and critical is 15%. And the type of SARS-CoV-2 sequences alpha, beta, gamma, delta, we have observed the delta infection, and now Omicron infection. In Bangladesh, COVID-19 pandemic puts an enormous strain on the country healthcare system. Facilities were found to be inadequate, null or prepared. The lack of available and accessible critical healthcare services related to COVID-19 created a major public health crisis all over the country. But there is no formula or operating manual for how to cope with the current global pandemic. OGSB from very beginning, its response by forming a guideline, COVID-19 and women's health, webinar to create the awareness of the people and the healthcare workers. IPC for Frontline Fighter program is a very renowned program of the Bangladesh. For the frontline fighter, we have shown the solidarity with frontliners. We have given the telemedicine services. About 4 lakh of the people take the services via telemedicine. And we recommend for vaccine for pregnant and lactating mother for government to start this vaccination, because from very beginning, vaccination was not started in Bangladesh. IPC for Frontline Fighter was given according to guideline of the WHO. 8 points were included during the meeting time. At that meeting, hospital administrator, frontliners, and the nurses was included in that meeting. These are the guidelines of the COVID-19 mother for their use, and these were circulated all over the country to help the mother how to give the treatment. And TRIAS flow chart was also given for the frontliner for the better management of the case. We have given PPE, how to use PPE, how to use PPE of the frontline fighter, and this poster was circulated and given in every hospitals of the country. And these are the pictures of our webinar for IPC for frontline fighter. Personal protective equipment for healthcare is very important because effectiveness strongly depends upon adequate and regular supplies, adequate staff training, appropriate hand hygiene, and especially appropriate human behavior. But training on this IPC was not adequate for the frontliners in Bangladesh. Timeline of our infection, January 2020 to March 2020, arrival into the Bangladesh, and the first wave 2020 to March to May 2020, first wave and general holiday was given, and this general holiday was extended in several times. March 2021 to May 2021, we have observed the second wave of COVID infection, and May 2021 to August 2021, we have observed the third wave COVID infection. The first death on Bangladesh on 18th March, the patient was age over 70 and then had other comorbidities. By the end of March, Bangladesh has reported 51 confirmed cases and 5 deaths. In second wave, relatively low number of infection occurs throughout January and February, but March show a rapid increase in infection, with positive rates increasing to over 23% in early April, whereas they had been below 5% throughout the February. On 28th April, the lockdown period was ended, prioritizing livelihood over that has been a mild illness in Bangladesh, and with some lowest death rates in the world. The country has reopened in accordance with the hygiene. These are the steep rise of infection rate in April 2021, and also steep rise of number of deaths in April 2021. Third wave, May 2021 to August 2021. IADCR confirmed community transmission of the Delta variant across the several districts. In 8 districts, rise of infection was 30 to 60%, and the nationwide positivity once again crossed 20% on 23rd June 2021. Towards the end of the June, several districts surrounding Dhaka went into lockdown again to try and to reduce the transmission into the capital. On July 1, 2021, Bangladesh went to another national lockdown plan to last 7 days. Testing facilities in Bangladesh. Bangladesh had lowest test rates per capita initially. Throughout 2020 and the first half of 2021, routine testing was not adopted in the Bangladesh. The number of tests conducted had typically been between approximately 10 to 18,000 per day, with the number of tests increasing as infections surged during a wave. As July 16, 2021, approximately 7.2 million tests had been conducted, corresponding to 1 test per 23 people. Gradually, the testing facilities are increasing in our country. Now, RT-PCR lab, 154 RT-PCR lab we have. We have Gen Expert lab 57 and rapid antigen test 646. And these are the features of testing capacity of the Bangladesh in relation with the India, Pakistan, Nepal, and Bhutan.
I'm sorry, we have 2 minutes left.
Okay. This is the last situation. Bangladesh total case 1.89 million and death is 28.703 million. But worldwide, 403 million and 5.78 million death worldwide. And this is the cumulative cases and cumulative death rate of Bangladesh. The case rate is also low and the cumulative death is also low in Bangladesh. Our Honorable Prime Minister given 31 indication or 31 guideline for the control of COVID. Vaccination in Bangladesh, we are giving Oxford AstraZeneca COVID-19 vaccine, serum from Sinopharm BIBP and Pfizer. Last vaccination. We have started vaccination 27th January and mass vaccination started at 7th January and total dose given in the 22 December 2021. These are the pictures of our ministers. Bangladesh dose given 156 million and fully vaccinated 59.7 million and percentage of total population vaccinated 36.6 million. And we have recommended vaccination in pregnant women and lactating mother also. And booster dose is given, and this is the last situation in Bangladesh from 3 January 2020 to 10th February, there have been 1.8 million confirmed cases and death 28,744 death according to WHO. Thank you very much for patient sharing of my presentation. Thank you.
Thank you, Madam, for your elaborating and enriching presentation on current situation in Bangladesh. Dear audience, we are running already behind the casual time, but now the most important and attractive part of the session. This question and answer part will be conducted by Professor Krishnendu Gupta, Sir, Professor and Unit Head of OBGYN, Vivekananda Institute of Medical Sciences, Kolkata. And is the FOXY representative to AOFOG, Chair, Sexual and Reproductive Health Committee, AOFOG. Sir, please, the floor is yours now.
Thank you very much, Madam, for this very generous introduction. At the outset, let me thank Professor Firdausi Begum, Professor Gulshan Ara, Professor Sheikh Zinat Ara Begum, for Nasreen, for giving me this opportunity, and the entire members of the Obstetric and Gynecological Societies of Bangladesh, and also, of course, to my respected Professor Kazunori Ochiai, Professor Pisek, and Dr. Rohana, and the entire executive board of AOFOG for this opportunity. Well, as you've heard, 4 wonderful speakers who have elaborated enough, but since Professor Sarikapan has another faculty meeting to run to, I'll ask the question directly to her so that she can answer that. There's a question for her to you, Professor Sarikapan, which is, during anti-cancer therapy, can we give the COVID vaccine? So if you can elaborate on this, I think, because we are all aware that during cancer chemotherapy, we do not give any vaccine, but then what about COVID-19 vaccine?
Thank you, Chris, and the audience. This is a very good question. As we can see that cancer patient is vulnerable to COVID infection. Therefore, COVID vaccination to prevent infection is very important, and it should be done. But this is very good question. Yes, the answer is yes. But during anti-cancer therapy, giving vaccination should not be at the immunosuppressive time. It should be further from that point. For example, cancer patient during chemotherapy, giving vaccination should not be at the nadir point, that with the very low white cell count or nadir point. It should be 2 weeks away from chemotherapy, either before or after. As well as radiotherapy, it should be like, for example, 2 weeks away from radiotherapy. And from surgery, vaccination, COVID vaccination should give, and then at least 1 week before major surgery, or completed surgery, and then for a week or two, then giving COVID vaccination. Thank you.
Thank you very much, Professor Sarikapan, and we are aware of your rush to the faculty meeting, so I would like to thank you for your time and for the preparation for this presentation. Wonderful as always. Well, the next question is to Dr. Ratnasiri, and the question is, during pregnancy, when would you prefer, or what are the guidelines to give the booster dose? So if you can, I mean, it was a wonderful presentation, Ratnasiri, as always. You've had a lot of research in your presentation, so it'll be nice if you can just give it in a little nutshell.
Thank you, Krish, for asking this question. This is a very relevant question. Actually, booster dose is the third dose considered to be, it can be the fourth dose also, but third dose is usually recommended after 3 months of the second dose. So that is the duration of the second dose activity, which is considered to be immune for the mother, and third dose is advised 3 months after the second dose. And women may get more boost doses in the future, but at the moment, I think the third booster is recommended after 3 months of the second dose to keep the immunity intact. So these guidelines may vary with the new developments, but at the moment, that is the rationale.
Thank you, Dr. Ratnasiri. And since we are already short of time, and I would, before handing over to the moderator, Dr. Kishore Sultana, I would like to recognize Professor Farhana for really communicating with me regarding this, and also remember with gratitude Professor T.K. Chaudhary, Professor Roshan Ara Begum, Professor Laila, and they've been really, really kind to me always, the society, and it was wonderful to be at the inauguration yesterday. So I would like to hand the session back because there are no further questions here, and we are already short of time. So Professor Kazunori is there with us, Dr. Rohana is here. So thank you very much for the opportunity. Back to you, Professor Sultana. Dr. Sultana.
Thank you, sir. Thank you very much. We are very privileged to hear the answer of questions. Thank you, sir. Now, I request our respected chairperson, Professor Muhammad Abdul Halim from Bangladesh, to make few comments on the session. Sir, please. Sir, unmute hote hobe, sir. Unmute.
Thank you very much. And I am very much actually privileged to be chairing such a wonderful session, and actually discussed by many of the resource person. I really very much proud to just mention the name of Professor Kazunori. He is pivotal in the AFOG to guide that advisory group and forming this idea and then going for the work. And he is president of the Professor Pisak, who has already actually presented on the advisory group's role and how it is generating the evidences and guiding guidelines and other things, and to guide the total region and making the linkage with the SAFOG and other organizations within the country and within the region, and to make this COVID and women health ensure that COVID infection is prevented and treated and all these things, and women health is secured. We have mostly discussed on the pregnancy and the cancer, but women health actually goes on the beyond its boundary, its other issues like gender empowerment issue, workforce issues, so many things are there. So there are lots of things remains unanswered and undiscussed, but that has the actual role of the advisory group to look into. At the website will be pivotal for us to get knowledge and knowledge base and generating and putting our experience into it. Maybe it is a opportunity. I also like to thank the Ratnasiri, who has been really elaborated the vaccination and its rule and how it can, even lastly she said about and ensured our OGSB member of Bangladesh also to ensure the third dose. You know, the vaccination is, okay, we are saying very easily, but for Bangladesh like country, when you think the uptake of the vaccination, we need to go for the awareness, knowledge building and other things, and also communication with the community, the people, the linkage. So there are lots of role of the organization like OGSB has to be in front to go into this effect, and also ensuring all the actually OGSB practitioners are ensuring the third dose even during this time. And Professor the Wheeler, who has been elaborated the cancer, not only cancer, we understood the cancer like immunosuppressive conditions when the COVID has got some other impact, and cancer has the impact on the COVID, COVID has the impact on the outcome of the cancer and the chemotherapy conditions and the immunosuppressive. Even she mentioned about the positively, yes, we have to vaccinate these people, but we have to look into the status of the immunization. Thank you, Professor Wheeler, to give us the light for these areas. Lastly, Professor Gulshan Ara, our Secretary of OGSB, General Secretary of OGSB, who has been actually elaborated and actually had little time to elaborate more on the Bangladesh context and Bangladesh rule. Bangladesh government and its societies really in hands and hand, they are moving together, and the condition has been for the women health we are thinking of. We are thinking of actually with guidelines and other things, and OGSB had participated so many IPC for knowledge building with the professionals, with the other people, and then distributed so many things throughout the facilities. And now the conditions, she started with our condition was not well prepared, but now we are a bit prepared, though the COVID has changed its genetic and other expressions and its infectivity and its disease ability, disease making ability. It's thanks to God, things will be happen in a good way, and things to be controlled and will be controlled. And our role will be as a professional will be very good. And all our resource person who has joined this one as a part of our Bangladesh OGSB, I like to thank and become very grateful. And definitely I thanks our OGSB team who has been organized such a beautiful session. Thank you very much. I hand over to Kishore Sultana, moderator.
Thank you, sir, for your valuable words. Now,
Kishore, can I have the permission of to talk for 1 minute? Kishore, this is for those speaking.
Yes, yes, madam, please.
Yeah. So Professor Kajunuri, Professor Pisek, Dr. Rohana, Dr. Krishnandu, Dr. Ratnasri, our Dr. Halim and Dr. Gulshan Ara, rapporteurs, and the moderators of the session. It's a wonderful session. It's wonderful, and I must be thankful to all of you, especially Dr. Kajunuri. I think he has joined very early and with us from almost from the second session and encouraging us. And it's so wonderful to know about COVID situation, the issues you are dealing with, and especially the vaccination. We are really grateful to you. I just pipped in to say our gratitude for being with us from the region to work hand in hand and guiding us and cooperating with us. Thank you very much.
Thank you, madam. Now I would like to request our Honorable Chairperson, Dr. Rohana Hatutua, for his closing remark of the session. Sir, please.
Yes. For this opportunity given, but I will be very brief in my talk because we are going past time. I think Professor Halim outlined and gave the remarks about all the presentations. I just want to add that Professor Pisek very nicely outlined the activities done by AFOG with regards to the COVID-19, the education, how the guidelines are updated, and everyone is kept informed about the recent developments, the most recent developments about COVID-19 with the COVID-19 corner and all the articles and the webinars and so on. So I have to thank Professor Pisek and his group, advisory group, for all the hard work done during with this regard. And then, of course, as was mentioned, Dr. Ratnasri gave a very excellent lecture on vaccination, and he really told us how important vaccination is in reducing the maternal mortality and morbidity. And it has really taken up now, and we are seeing the results that most countries have taken up to vaccination of the pregnant mothers. and the maternal morbidity and mortality has shown a reduction. So then the advantages and that the side effects are very minimal, and the serious side effects are very rarely seen. So there is no, there is no reason not to take the vaccination during pregnancy. And then Professor Sarikapan also very adequately he showed the changes, the challenges which were faced due to COVID-19 by the cancer patients and also those who are treating. And we had to take some changes had to be made in the management and also diagnosing seen patients mainly by telemedicine and so on, and how the surgeries have to be cut down, and the radiotherapy and the chemotherapy, the visits to the hospital has to minimize, and so many changes had to be done because of this COVID-19. Because the COVID-19 has increased, is a high risk to the cancer patients. So that is one. So then, of course, we were given a very good outline of the situation in Bangladesh by Professor Gulshan, and we were very happy to say that Bangladesh is doing very well in controlling COVID-19 with the vaccination program being done very effectively, and so the government also supporting. So that is very encouraging news, and that even for the pregnant mothers being vaccinated. So all in all, this session was very, very informative, educative, and I think it was a very successful program. And I have to thank Professor Kasunori Uchai, our president, who is really behind all this, and he is driving us and guiding us in all these programs. And thank you very much. And also Professor Krishnendu, who really moderated the question and answer session and gave some real enlightenment and to the program. Thank you very much. And thank you, Dr. Sultana, for moderating the session. Thank you very much for everybody. And all the participants, I request you to remember A4G 2022, which is around the corner. It is in May 21st to 23rd. So kindly go to our website, A4G website. You can register online, so there is no issue. And mostly, I think under the circumstances, we may be able to be there in person. So I know every time the Bangladesh OGSB comes with a very big team. So this time also, we expect your great team under the leadership of Professor Ferdosi Begum, and you can see Professor T.H. Chowdhury being felicitated there this time. So I think you have to be there in large numbers. So inviting you to the A4G 2022, I conclude my remarks. Thank you very much.
Thank you very much, sir, for your nice, analytic, and inspiring remark for us. Now we are at the end of the interesting and interactive session from which we are very much benefited. So I request Dr. Sumaya Akhtar for giving vote of thanks. Thank you.
Thank you, Professor Kishore Sultana, for your wonderful moderation. It is my pleasure to thank the honorable chairpersons for conducting the session smoothly and successfully. My thanks to the speakers for their excellent deliberation, which has enriched our knowledge enormously. I will also give thanks to the pharmaceuticals companies who have supported us to organize and accomplish this session. Thank you all. Now I will hand over the microphone to the rapporteur of the next session.
This is the time for lunch break. Sumaya.
Lunch break.
Yeah.
Oh, sorry.
Kishore, I'd like to thank Professor
The next session starts at 2 p.m.
At 2 p.m., yes.
Kishore.
Yes.
Sir, I would like to thank Professor Kajunuri YC, President AO FOG, Dr. Rohana Hatatua, Secretary General AO FOG, Professor Abdul Halim, Principal Komudini Women's Medical College, for their presence, for their remarks, for their encouraging words, for their inspiration for us. Thank you very much for your presence. Your presence enlightened our session. Thank you very much.
So Kishwar, can I say a word?
Oh, yes, please.
I would just like, it was really a wonderful session. I would like to thank our respected Kajunuri sir, Rohana sir, and Professor Krishnendra Gupta for being with us, and Dr. UDP Ratnasiri for excellent presentation. And we were so much enlightened. Also Dr. Sarika Pan from Thailand. That's all I have to say. Thank you so much.
Thank you for inviting us. Thank you very much.
Welcome, sir.
And goodbye.
Thank
I
you.
hope to be there in Bali in person. I don't know what is
Yes,
going to
please.
happen.
Yes,
Hopefully
you
it
could.
is.
Yes.
Yeah.
Sir, madam, have a great weekend. Thank you very much from Bangladesh OGSB Society. Thank you.
Thank you very much.
Bye-bye.
Okay. So enjoy your lunch.
Okay.
Yeah, thank you.
Okay,
Thanks,
bye.
Dr. Tisek.
Most of the time self-planned.
Yeah. Post Dr.
Take care.
Kajunuri.
See you in Bali.
Okay, thank you. Thank you so
Thank
much.
you. Thank you.
Thank you.
Thanks to our team, OGSB team. Thank you so much. Well done.
Thank you, madam.
Thank you.
Thank you, Appa. Thank you.
অনেক অনেক ধন্যবাদ।
Recording stop.
Thank you.